We exist in their unceded homelands. We also acknowledge the uncomfortable truths of the settler colonialism, among them that the indigenous people, often forcibly removed from this place. Harm from the physical and cultural genocide of Native people here and throughout the land we now call Maine continues and is felt by members of the Wabanaki Confederacy who live here today. To participate in the healing process, please visit the organization Wabanaki Reach at wabanakireach.org, MaineWabanakiReach.org. We all have work to do. So, what is on the agenda today for you guys? Again, I apologize for you cannot see much of the agenda. It's up here, but I'm going to be reading that out loud to you. We will be focusing on the question, what is equity? Afterwards, I have the honor of introducing our keynote speaker, Mrs. Minou Jones, the chair of the Detroit-Wayne-Oakland Tobacco-Free Coalition. Following that, at 10 a.m., we will move into public health panel, featuring some of the amazing experts, and will be moderated by our good friend, Carol Kelly. We will take a short break at 11 a.m., so feel free to stretch your legs and walk around. At 11:15 a.m., we will dive into Maine's oral health landscape panel, where you will hear from state leaders on this crucial issue or crucial topic. Then we will break for lunch at 12:15. In the afternoon, at 1:15 p.m., we will focus on local efforts with Regina Phillips, presenting findings and recommendations for the Oral Health Equity Collaborative. Finally, we will wrap up around 3 p.m. with closing remarks, acknowledgement from our own co-founder, Regina Phillips. Thank you once again for being here. It's going to be an exciting and impactful day for all of us, and we are so glad for each and every one of you to be here with us. So now, let me introduce our amazing keynote speaker. Minou Jones is the founder and CEO of Making It Count Corporation, Making It Count Community Development Corporation, a black woman-led 501c3 nonprofit organization whose mission is to provide meaningful opportunities that count towards making a difference in the overall equity and quality of its community's members. Jones previously served as the CEO of the Black Caucus Foundation of Michigan. Mrs. Jones has more than 20 years of experience in the field of community development and public health. Her organization, MIC, is currently spearheading an effort to reduce tobacco-related disparities in Michigan. She also serves as the chair of the Detroit-Wayne-Oakland Tobacco Coalition and is a board member of the Tobacco-Free Michigan. Mrs. Jones is passionate about helping people of color build healthier communities. She's an internationally certified prevention specialist and alumni of Wayne State and Davenport Universities. In 2023, Mrs. Jones was awarded the Health and Racial Equity Partner Award by the National Network of Better Health Institute. Please help us welcome Mrs. Minou Jones.
Give me a second here. Good morning. All right, so in Detroit, our greeting is what up, though? And when we say what up, though, your response is what up. So what up, though? What up? There we go. So thank you so much for the introduction. I also want to start by acknowledging our partners. So Campaign for Tobacco-Free Kids, Center for Black Health and Equity, Minou Jones Foundation, and of course, cross-cultural community services. Thanks again for having me. So, I'm a native Detroiter with an axe to grind against the tobacco industry. That's who I am. When I talk about tobacco, and I'll only be talking to you for maybe about 15, 20 minutes. When I talk about tobacco, I want to ensure you that we are not talking about sacred tobacco. We are talking about commercial tobacco that's manufactured and sold for profit. Okay? Next slide, please. Okay, so this is how we're going to start the day off. Now, I'm going to step away from the podium at times, but this mailer right here, it says, Kamala Harris and the Biden administration are worried about banning menthol, and they should be worried about giving you money to pay your rent, buy your food, and all of this, that, and that. Now, this is not a keynote or a speech about who you should vote for. It's not that at all. I bring it up because I left DC, Congressional Black Caucus Conference, on Sunday to be here. But on Thursday, while I was at that conference, I started getting a bunch of text messages and calls about this mailer that hit the homes of Detroiters. And the calls and texts came from friends, from coalition members, from colleagues, from people who know about the work that I've been doing in Detroit. And I brought this flyer up because it is an example of the critical and crucial role each of us plays in educating our community and providing resources so that when things come our way that are misinformation, we are alerted, we know the truth, and we can provide factual information, because we all want, or should want, everybody, regardless of your race, color, or sexual preference, to have the opportunity to reach their highest health potential. That's the point. So, I want to just see who I have in the room today. If you work in oral health, stand up. Thank you. If you volunteer for a nonprofit organization, volunteer, stand up. If you belong to a coalition in Maine, please stand up. And I bring that point up because we all have a role to play, right? And the community is here. Next slide, please. So when that mailer came, there was an article that was published, and it was sent to me, right? This is all happening while I'm in DC. And I didn't need to respond. The article does not have my voice on it one time. What the news reporter that interviewed people, he reached out to Reverend Wendell Anthony, who serves as the president of the Detroit NAACP chapter. And this is what he said: "It's insulting. It belittles the intelligence of the African American community." Right? Having outsiders come into your community and tell you what you need is not the way that we should be doing this work. It can't be a top-down approach. Maybe you work in a higher level position. Maybe you are an elected official. But at the end of the day, we are all part of a community, and we should be working as such. Next slide, please. So my axe to grind. We see that 85% of African Americans use menthol cigarettes compared to 29% of white smokers. half of youth who have ever smoked initiated with menthol cigarettes. Preference for menthol among is also disproportionately high amongst lesbian, gay, and bisexual smokers, smokers with mental health problems, socioeconomically disadvantaged populations, and pregnant women. So it's not just a Black issue, right? It's not, but it hits harder for those groups. Next slide, please. Each year, approximately 45,000 Black Americans die from tobacco-related disease. Cancer, heart disease, stroke, they're all there. So, in the introduction, my good friend Jacka, announced that I was the president and CEO of Making It Count. That's been my mantra since I was a single mother with 4 kids. If I have to go through something, if I have to be in this space, let me make it count for something, right? And so at this time, as we think about equity, right, and infrastructure, and oral health, this is not just about your paycheck, right? It's about an opportunity to make it count. You're not going to get rich as a volunteer for a coalition, not financially anyway, right? And we know that elected officials and people in this work don't do it for the money. They do it because they have a heart for service. So at this time, I want to invite our ancestors in the room so that when we move forward in our conference today, we have them here and they know that we're doing this work for them and for the future of our communities. So if you have lost someone to cancer, please stand up and remain standing. If you lost someone to stroke, heart disease, or emphysema, please stand up. If you know someone impacted by hypertension or asthma or COPD, please stand up. Diabetes, anybody? Look around you. I said 45,000 Black people, and my father was one of those people. I lost him in 2022. Our ancestors are looking towards us to do this work. And it's hard work. It doesn't come with a whole lot of financial reward, but it's worth it. It's worth it for the future generations, and it's worth it for us to make those things that we've gone through, that we've witnessed our family members going through, the suffering, the pain, the financial debt that's associated with it. We're here, we're doing this conference, not for CEUs and credits, but because we are here to make it count. And I honor you for the work that you do. Please take a seat. Advance 2 slides, please. So this is a picture of me and my father, Christmas 1987. I was in my first year of high school, and as you see, I like to dress, it runs in the family, right? So my daddy was all dappered up. This is Christmas time. He's walking out the door, and I'm hugging him, and as you can see, he has a cigarette in his hand. It's a menthol cigarette. I grew up with 2 parents who smoked menthols. At 5, my mom asked me to go across the street to get her a pack of cigarettes. This was before there were laws, age restriction laws. And when I went across the street, I was hit by a car. Right? I had plastic surgery from my leg, grabbed that skin to my face, and it wasn't until 3 months, I guess it's been about 3 months now. 3 months ago, I went to the hearing aid specialist with my mom because I can't hear, y'all. And I found out that it was related, my hearing loss was related to that car accident. Didn't know it at the time. Right, so when we think about prevention, when we think about the work that we're doing, know that you might not see the impact right away, right? You might not understand the devastation that occurs right away, right? COPD, emphysema, those types of chronic diseases, they're long-term in most cases, right? But it matters. It matters, and we can do so much about it. I lost my father in November of 2022. He was a man who would walk to work, ride his bike to work. During his final days, he couldn't make it to the bathroom. So to receive that type of mailer, right, in the mailbox of Detroiters, where we're still 80% African American, we have the highest incidence of infant mortality, of asthma, of, chronic disease and death. To receive that mailer, it is insulting. It is insulting. Yes, we need food. We need to pay our rent. But we're suffering beyond that. Our health is suffering. When you don't have good health, you can't run it to your full potential, right? So prepare. Prepare yourself and prepare your communities, because we are at war. We are at war against corporate greed that likes to appropriate our culture, pay off our civil rights leaders, benefit from our poverty, our stress, and we're looking for a way out, and you send that type of mail. How dare you? It's not okay. I asked you if you belong to a coalition. I asked you if you did volunteer work, because we cannot sit at our desks and do this work. We cannot isolate ourselves in this work. We have to step out and get to the community. So as Michelle Obama said, I'm giving you this invitation right now. You're not going to receive a special phone call from me. So if that's going to be your excuse, cut it out. We don't have time for the foolishness here, folks. We're in a fight for our lives and the lives of our kids. There are over 15,500 flavors on the market for e-cigarettes right now. 2 million youth initiate use of tobacco products each year in the United States. There was a study recently by the CDC Foundation that said e-cigarettes in the past 3 years, those sales have gone up 622%. What are we doing? I've seen the fight. I'm in the fight too. When I was here in February, I had the opportunity to talk to elected officials. And I will tell you, it's a humbling experience as a Black woman to ask a non-Black person to push the button for my people. My people are suffering. Our kids are suffering. But when I look at the legislature in Michigan and in Maine, I don't see a whole lot of people that look like me up there. The civil rights movement was not won by only having Black people there. Right? Mm-hmm. We have to stand up and stick together. What we don't have is the money to match the $5.3 billion that tobacco companies spend on marketing and advertising each year. But what we do have is people power. So let's unite. Let's go forward in our agenda today. And keep in mind those ancestors that you stood up for at the beginning of today's session. Keep in mind those 2 million kids that are being targeted and enticed into lifelong addiction to tobacco products. Keep in mind that oral health and equity, there is an opportunity for you to impact the community because you are the trusted members in the community. Right? It's not just about getting your teeth cleaned, but I will say that it was an eye-opener for COVID because when I put that mask on, I said, Minou, you gotta do something about this mouth. I said, how many people smell their own breath? Right, but it goes beyond oral health. And so I want to thank you for having me here today, for inviting me, and I want to charge you with understand the policies that have been drafted. Join a coalition. Policy creates population level change. Yes, we work individually, but this fight requires good policy, strong policy. You have to know what the policies are, and you have to be able to translate that language down to 3rd grade level reading. It shouldn't be a whole bunch of words and acronyms when you speak to an everyday person. Right, so charge with that. Join a coalition if you don't belong to one. Research and understand the policies and what's at stake. And be able to translate that information when you speak to other people about the issue and bring their ancestors along so that you instill hope and trust and passion in the work that you do. Thank you. Ooh, hello. Hi. Sorry. Just trying to make up for us being so late.
Well, thank you. Thank you so much. We're so honored that you're here with us today. So thank you. That was absolutely wonderful. Wonderful message. And so we are going to get to our panel in just a minute, but we have a video to show you because why we're here today is, and it gets back to what Minnou's saying, what is equity? What we want to know is what is equity within our systems? And so we asked folks, what is equity? We're going to stop the panelists are going to come and they're going to tell us what they think equity is across systems. And so we're going to show you this video, and we apologize. We've had some major technology issues this morning, and the screen is one of them. And so we know you can't see it very well, but we're going to go ahead and show the video because we really, truly think it's important, and it will begin the conversation that we're going to be having with our panel. So we're going to take a few minutes. It's literally just a couple minutes. We're going to show you this, and then after that, I will call the panelists up to the stage.
We're recording, I can tell. Dear middle schooler, I always think about this cartoon cartoon that I have seen, and I think it's people trying to watch a sporting event. It's comparing equality and equity, and equality is giving everyone the same size platform to stand on, but then you have someone who's already very tall, someone who's like a young child, and someone who's in a wheelchair, and that same box doesn't work for everyone.
I think equity at its center, like trying to create a culture and systems where people can feel safe.
Providing people with the resources that they need so that everyone has equal opportunity. Equity is assessing like what do each of these people need to be able to watch that sporting event instead of just trying to give everyone the same thing. It's giving people what they need to access the same opportunity.
In the world of oral health, we are bringing in hygienists into child care centers to provide oral health care to children. A lot of these families don't have the ability to take time off of work. They don't have transportation to get their children to appointments. So by bringing the resource to them, we are creating a more equitable system.
The dental system that some of us are familiar with, was never actually intended to serve everyone. IPON is really working to build a system that can actually meet the needs of everyone, and that's informed by people from all communities that have been most left out of our current dental system.
We need our education system, our elected leaders to all be talking about the real experience of people. If you don't have enough money, then it can be a real challenge just to even put food on your table. The only way we can fix it is to rebuild those systems in a way that works for everybody.
Everyone has a chance to live their life to the fullest potential. It's important because it's not protected by law. Sometimes when people hear equity like myself, and you just asked me that question, I was like, how do I define it? And for a lot of people, it helps to have guidelines, it helps to have policy, to have laws. The foundation inherently was built inequitable. And so you need to bring people to the table with multiple identities that can speak up and say, this is my input on it, this is how you can make it equitable.
So I'm going to do one thing before we bring a panel up. I just want to get back to something you said, which is our policymakers. And so two things. One, if you are a policymaker or you do policy work, would you please stand up and be recognized? Anybody who's doing policy and policy work? The other folks that I want to recognize, if the folks that are involved in the cross-cultural community services, Oral Health Equity Collaborative, if you could all stand up and be recognized as our partners, that would be lovely too. Thank you. And so we are so excited to give this the second part of our conference. We put together a dynamic panel. And so I'm going to ask folks to come on stage to introduce themselves, and we will get started. First, we have Minou Jones, making a development corporation. Liz Blackwell-Moore from Cumberland County Public Health. Morgan Hind, the Binghamton program, and it's going to be moderated by Carol Kelly.
Hey everybody, I'm Carol Kelly. We'll give these guys a second to get situated. I know many of you here, and it's so great to be here. I do public health consulting work. I do a lot of policy work, but I also do a lot of communications work. And really, I get a chance to just work with groups that are looking to figure out how to not just change systems, but rebuild systems. And so when Regina and Becca asked me to brainstorm how we could make best use of Minou while she's here, because I had a great opportunity to spend a couple days with Minou in February on tobacco specific, we just said, hey, let's pull together a group who can really talk about, from that policy lens, down to what's the infrastructure needed? What do we need to build for systems and structures if we don't already have it? What do we have that's already working? And how do we make sure that what we've got is really able to help everybody? Again, that equity lens. So we want systems and structures that actually allow for equity to happen. is, I think we can probably all agree, not the case right now. So this is a chance to hear from Minou and her national perspective and Michigan perspective, a chance to hear from Liz and her county, very innovative county level perspective, and then from Morgan from the lens of a funder who's doing this amazing work to invest in systems and structures. So that's I guess I would say the context for this conversation. So they're all going to kind of give you a few minutes of just a little bit of an overview. I sent them a few like, hey, talk about this. I don't know if they're going to do that or not, doesn't matter. But then we're going to have fun because we're going to see what they all say and we're going to mix it up. I might ask a few more questions and then we're going to open it up to you all for some potential questions, comments, and additional thoughts. So that's what we're gonna take. And for the folks here, feel free to just hold up the hey, you've got 5 minutes or whatever you need to do to tell us to knock it off. Okay. So good. I would love to, Minou, if you don't mind, I'd love to start with you because you sort of bring to us the perspective of not only another state, a state that has a different way of doing government, a state that has a different way of doing your infrastructure, your community-based infrastructure. There's probably some overlap and some not. But also you have that national perspective of what are you watching other states do, what do you watch, how does the federal component of either funding or programming really impact the community level infrastructure and capacities in getting stuff done.
Okay. Can everybody hear me? Yes. All right. So, when I founded Maine Community Development Corporation, we were looking at our, mission statement. In our mission statement, it is to provide meaningful opportunities that count towards making a difference in the overall equity and equality of its community members. So, in Michigan, for years, it was a top-down approach. Michigan ranks 50th in the United States for tobacco control funding, according to the Center for Disease Control. We tied with West Virginia. We are part of Tobacco Nation, which is a set of 13 states that have higher rates of tobacco use and higher rates of disease and death attributable to it, lower life expectancy. We're part of that illustrious group with all of the other southern states, right? So knowing that, right, and the CDC recommends that, 2% of your budget is allocated towards tobacco control, but Michigan only gets $2 million. We don't have e-cigarettes taxed in Michigan, which would bring in $300 million worth of revenue, which is triple the recommended amount for CDC funding. So when we look at policies and what's been happening in Michigan for close to 30 years, there are some similarities. We haven't raised our tobacco sales tax in over 20 years, similar to Maine. Unlike Maine, we have preemption. So when we started this work, and we were focused on Detroit, but very quickly we hit a brick wall in learning that local municipalities cannot pass laws that are more stringent than state law. We didn't look at that as a killer, as a hard stop. We looked at it as a pivot to include more communities across the state and to really start educating and providing those meaningful opportunities for community members to stand up. Because what we know and what we've seen in the past 4 years in Michigan is community voices really do make the difference when it comes to passing legislation that has been on the table, that has gone through all of these challenges. Sometimes you get funding from national organizations, they pull out, then you don't have funding, then they see that you're doing good work and they want to jump back in, and all the while you're running a nonprofit and looking for grant money to sustain your staff and programs. The way out of that, is by reconfiguring this whole systems approach, right? The systematic approach was not built for people of color. It was built to suppress us. And so if we continue to work in that same system and follow, those same formulas of what works, what's evidence-based, when we haven't been included in those research studies, we're going to continue to come short. And so the way out of that is to look at the resources that we have. Look at what works. Invite more diversity to the table, and begin to empower them. You can't bring people to the table at the 11th hour and tell your story. It's insulting. Include people on the front end. You don't have to be a lawyer or a politician to do policy work. You really don't. But there are trainings that we do. One of them is called Storytelling Through Advocacy. That is through the Center for Black Health and Equity, where we go to community members, and we give them the skills that they need to get out of the routine of only talking about the problem. They are part of the solution. They are the experts. They have to be at the table.
Thank you so much. That's a perfect bridge, Liz, to you, because I'd love to hear you kind of build on that and add whatever you were going to say anyway. Because what Liz has done is kind of amazing, let's face it, which is to basically build public health capacity and infrastructure in a place that it didn't exist. And there's obviously, it's a work in progress, and I heard you say last night when we were chatting that, some things still need to be connected. There's some connective tissue that might be missing. So I'd love to have you add your thoughts here.
Sure, yeah, so, again, my name is Liz Blackwell-Moore, my pronouns are she, her, and I am the director for public health.
The mic.
Oh, the mic. Thank you. Can you hear me now? Okay. The public health department was started a few years ago, and I was hired to essentially figure out what our role should be at Cumberland County Public Health when there is, centralized public health system in the state. There's city public health at City of Portland. What is our role? What could we be doing? And so, I think one of the things that I think a lot about is about coordination and capacity. And that I have seen a lot of amazing efforts that are happening at the local level, and ideas of what could be happening at a state level. I think there is often a real lack of coordination, and when organizations who are very community-based organizations, they aren't funded to do collaborations necessarily or coordinate their efforts. They're funded to do specific programs to work within those communities. They have deep knowledge, deep connection, and deep relationships, and yet not enough adequate funding and resources to then have a coordinated approach where that knowledge and what is happening gets brought up to the state level or to even a district or a county level, where we then understand more deeply what the needs are and what needs to happen. So, I think one of the things I've been thinking a lot about when you provided some questions to me, Carol, was where I've seen some infrastructure work really well. And I think there are a lot of examples. But I guess I want to share one that I think illustrates just some work we've been doing at Cumberland County Public Health, and that is to really support and build capacity where there's already things happening. So in South Portland, there's an organization called SoCo Unite. Many of you may have heard of them. They're a drug-free community coalition that's funded through the federal government to do substance use prevention work. Through that work, the woman who runs that, she's funded to do, Leanne, she's funded to build community capacity. Like half of the money is to go towards coalition building. That's pretty rare that there are coalitions that have that kind of capacity. But what she does is she's able to bring people in and really provide like level setting of like what are all the reasons why people are at higher risk for substance use or have more protective factors that protect them from substance use. And so through that, the community there has really been able to identify like, oh, there's actually all these community conditions that are impacting why young people start using. And so one of the things they've identified over time is the lack of transportation for young people to get to meaningful after-school activities, and that the young people keep saying, well, we can't get to the field where our sports are, or we can't get to the job at the mall because the bus doesn't take us there. And so she worked with staff that we have that have additional capacity. They have some connections to other leaders in the community who can make some change, and so they work together to support this group of young people to figure out what are the key barriers and what are the young people's, what do they think should happen? And they presented that information as a group. So we needed the community, the person on the ground who's helping to support this for those young people. Then they went to a group of like 16 or 17 leaders in the community and said, this is what we think should happen, what we want to see happen. There were already things brewing in South Portland around transportation, but it has been really, I think they're adding their voice to that work has been really instrumental in the council voting towards thinking through transportation efforts that are making the bus system work better for the people who live there. And so I think that part of it is, it's like having the funding and the work to collaborate between and coordinate efforts, but also having access to people who can make change, like who can pull the levers, right? Like who have the power to do that. So I think there's ways in which that could get replicated in so many ways, and yet organizations don't have the capacity to do that coordination role. And I think it's vital for my organization, us at this county level, to be deeply connected to those community-based organizations so that we can know what the needs are, so we can support them in capacity building. If we have funding that we can funnel their way, or if we can build their capacity to get their own funding to do the work. But I think this coordination is very much missing at the level that makes us really be able to make change around community conditions. I think culturally we've understood now that social drivers of health and like where people live and what are the access to resources have the most impact on people's health and well-being. So to impact those things, we have to be working together to do that, but we need funding and resources to do that.
Awesome. You want to say more about the
Oh, well, I guess I mentioned to Carol, I think one of the things, the way I've been thinking a lot about our work is what's called targeted universalism. I'm not sure if many of you are familiar with it, but I think it's been created by the Othering and Belonging Institute at Berkeley, and John Powell has really been a leader in that. And it's really thinking through how do we develop, so instead of doing universal things, right, like where we say, oh, all people will be better if we do this one thing, but actually we know that folks who are most marginalized will not, we actually might really be increasing the inequities between them if we do universal strategies. And if we do just targeted things where we think like, okay, if we just do targeted interventions with one group, that will be good because we'll bring them, we'll support them to reach their more health. But that has implications where people say, oh, well, you're helping one group over another. Targeted universalism is essentially saying, well, what's the goal? What's the goal we have? And the goal that we have is that, in the case of young people, all young people can get to that, all young people have opportunity to do after-school activities that are meaningful to them. Or all young people have preventative oral health care once a year. And then we say, okay, well, where do all different groups of people sit within cultures and structures, systems and structures of a place? And how can we support those people to meet that goal? And so it's a little bit of a flip. It's not like how do we give people access to something, it's how do all the people who live in this place, how are they all going to reach this goal we have? And we need to do different things to help and to support folks to reach those goals. So I think it's a lot of how we think about the work that we do and sort of grounds our work. I'm sure there's other examples I can give later when we're talking through it a little bit more, but I think I just wanted to share that as like a principle that I think is an important part of creating infrastructure and systems that are going to actually work for all people.
Thank you, Liz. I think that's a piece of this that I'm really hoping, Morgan, you can kind of build on too, which is this idea that sometimes we actually aren't starting from a place where we can just keep adding stuff. Sometimes we have to tear stuff down. And sometimes we have to just really rethink, like, well, where did this idea, or where did this program, or where did this piece of infrastructure come from? Oh yeah, up there. So let's actually hear what's happening on the ground and then build up. And I don't think there's a funder in Maine doing more of this than the Bingham program in Morgan. So I'm just thrilled that you're here. So thank you for joining us.
Thank you. And actually, yes, the Bingham program is doing a lot of this work, but there are other funders, and there's at least one of them in this room. Well, the folks here will know the Children's Oral Health Network, and that's the Sadie and Harry Davis Foundation has really been instrumental in making all of Becca's work possible. And we work with a bunch of other philanthropic partners, specifically in oral health, to do this kind of systems change. And so, Bingham is a partner in it. I think that maybe we're a little more vocal about about how we feel about this. So I'll just introduce myself quickly. I know a bunch of you, but there are a lot of folks I don't know. Morgan Hine, I'm the director of the Bingham program. And the Bingham program is a statewide health-focused philanthropy, and so we do fund work around oral health, but also addressing adverse childhood experiences and creating opportunities for positive childhood experiences. We do some funding in the areas of healthy aging and community health more broadly. So that's just to ground us. But in terms of the systems change, I think as a funder, where we're evolving into is understanding that the culture change is about kind of what Carol just said, which is no longer looking to the top of the pyramid for the answers, but looking to the community for the answers. And it's supporting all the work that Minou and Liz was talking about earlier, and figuring out the infrastructure that we can create to support all of that work. And so, Bingham has long been engaged in work around public health, and what we understand to be true in Maine is that there is a real lack of infrastructure around the state, particularly more at the county, municipal levels, to support good health for our communities. And so Bingham is exploring work that will hopefully find new paths to this infrastructure and supporting infrastructure in communities. And we're sort of calling it community hubs right now, but I think there are lots of different ways of thinking about this. And there is great work happening in communities all over the state. Liz has just talked about what she's been doing in her community, but this is happening everywhere. And I think ultimately it's an acknowledgement of that good work that's happening and building on the assets that are already in communities. And those are the folks who, they already know what the health challenges are. So we honestly don't even have to go through the identifying part, because the people are living this every day. So they also know what who the people are, what the assets are, and how to address these challenges but they don't often have the infrastructure or the support there to help them. So what Bingham is doing right now is exploring a lot with Carol's help, exploring how we can work with more local government to support that infrastructure, because what we've seen in the past is when this kind of work is top down from, say, the state level down, the political winds change and everything that we have built disappears. And so we want to create an infrastructure that doesn't disappear depending on who's governor or who is president. And that we get to keep doing this work no matter what. And I think when you have the investment happening at a more local level, those folks understand why it's important because they live in that community. But when you have someone at the state level making decisions about what you're doing every day, they have no idea what's important about the work that you're doing. So that's what Bingham is working toward, and we're trying to learn as much as we can from all of you, and the hubbing work that you're doing around oral health or any other public health work or equity work that you're doing. We really need to learn from you to understand how we can make this work and how we can get that local investment.
Thank you so much, Martha. So I'm going to kick it off. This is going to be like a modeling what's going to happen next for you all. So start thinking about what you might want to ask or add to this conversation. I'm going to add one or ask one thing, and then I'm going to turn it back to you and keep this conversation going and with your insights and expertise. So one of the things that I think we often say, many of us say, and some of us observe about Maine is it's 2 degrees of separation, right? So you don't need to know 5 people to get to that one person you're trying to talk to. You just need to know one person, they're going to know them, and it just always seems to work that way. We also have in Maine, because of our closeness and our relationships, and we oftentimes solve problems, identify problems, and solve problems because we know somebody that we can call to make something happen. And so that's great. And yet it's also completely limiting, right? Because if we're limited by the perspectives of the folks that are both identifying the problem and potentially solving the problem. But on the other hand, there's this deep sense of community. And I've watched it happen, and I'm sure many of you have as well. When something is really happening out there that needs to get fixed, or there's an opportunity that isn't being addressed, people come together. People want to come together. There's the stacking wood when somebody's sick. There's bringing over a casserole. There's all those things that actually happen in most parts of Maine. How do we build on the closeness that Maine communities have? How do we use that to our advantage to move towards a system and an infrastructure that works for everyone? Have you seen examples of this in your work where you think, if we could just do that everywhere, it would make a difference? And Minou, particularly, I'd love to hear if you think this is like part of the culture in Michigan. And then the last thing I'll say is, it's not really the flip side of the coin, but it's really related, which is that we also are wicked independent. And so it's not really that easy to ask for help sometimes. And so how do we use these intangibles and make change? So I'd be curious to know if you have any perspective, if any of you have any perspectives on that.
Yeah, I can speak to that. I do think that, for one, a lot of times we look to communities and we look at their deficits, right, where they're short, when we should be looking at them from an asset base, right? It's empowering, and it helps us. Does anybody do logic models in here? Right? Okay, anybody grant writers in here? Okay, I know we have some funders, right? Those are all assets. When we look at the community-driven approach, when I became the coalition chair for the Detroit Oakland Tobacco-Free Coalition, we had 23 members. Today we have over 100 members, and it's been 4 years. So how, right, how? Well, one, I received some funding through MDHHS, which is our state health department, and you know how when you have to do your report at the end, it says technical assistance needs, right? A lot of people leave that one. I don't. And so in that first year, my project officer was amazing, right? What I said on that technical piece is, I want you to provide me with the opportunity to speak nationally, and I want you to provide me introductions with national partners and organizations. Okay? That brought in American Heart, American Lung, Campaign for Tobacco-Free Kids, and the Center for Black Health and Equity. Center for Black Health and Equity came in and provided our coalition with a 5-part training series called Community Capacity Building Training. That training helped us organize our coalition into 5 committees. On the front end of that training, the first part was the historical context. And when I think about oral health and equity, and I think about my dad who had gingivitis and lost all of his teeth at 40, right? He was a black man and not somebody who went to the dentist because of the experiences that he had with going to the dentist as a child, right? So when we do this work, number one, yes, we need help from state and national partners, right? They have assets, they have resources. We need to be capitalizing and utilizing those assets, right? They have them. They taught us about power. American Heart came in and taught us about power back, right? Once we had the historical context, those few coalition members, we looked at what's the problem, right? We do logic models. We say, what's the problem? Why? But why here? You know? And so those pieces help the coalition members really frame and understand what the problem was, why it existed, and identify within their own networks who else should be at the table for this. And that's how we grew our coalition. Of course, you need small wins along the way, and this is tiring work. You get people to come, they come and go. But what you have, you know, moving forward, whether there's funding or not, is the start of the infrastructure in place so that you can attack multiple problems. So, you know, just as an overview, our coalition now, we would do funding, you know, a standard report. Now we still do the funding report, but we do an hour-and-a-half coalition meeting. This came about during COVID, right? And we learned from the virtual piece that we get more participation. Who knew, right? So we do virtual. And then we have those 5 committees. So there's data and evaluation, policy, education and community outreach, community mobilization, and cessation. So there is a spot for everybody that comes to the table, and there's a chair that we pay a small stipend to once a month to keep it going, you know, to keep that energy going. Those are things that have really helped us, right? It allows for non-public health members to be at the table, the parents, the youth, the retailers, right? We just started a program, we launched it in July, called Tight for Life. Tight is something that we talk about for our clothes, our hair, and all of that, right? That comes from the community. Tight for us is for transformational intervention grassroots health training. And what we realized was that if we're going to look at cessation, if we're going to look at really bringing people, resources to people, who are the trusted gatekeepers in the community that people frequent? Well, in Detroit, we frequent the beauty and barber salons. We are there. I don't care if you ain't got no groceries. We're going to get our hair done. We're going to get a haircut. That's what we do. So we leveraged the beauty and barber salons and brought in, you know, education and resources for them. They're Type for Life ambassadors. And when we first started in July, we focused on tobacco. Now we have NBHHS who's come to us and asked if we could add in cervical screening, cervical cancer screening, and breast cancer screening. So it really is about looking at the assets in your community. You know, it doesn't have to be a cookie cutter approach. You can do something different. You can. And then building on those assets. So it's so important.
Thank you so much, Amy. Does you want to add in there?
Yeah, sure. Do you know? So they can hear me. I think I'll just add that I think in some ways I'm hearing also that funding relationship building. Like there is, it's seeing the value of a relationship building and funding relationship building. And understanding that the people in communities know deeply what needs to happen, but how do we support them and continue to fund the things that they know need to happen, right? And fund the relationship building that is critical for making the changes. So I want to just give a little example. I was thinking about the Cumberland County Oral Health Project, which maybe will be talked about later, but there are people doing so much incredible work already. The ingenuity of people in Maine, I think, runs very deep. And so bringing those folks together, paying people to say okay, we know you've done amazing things. Can we pay you to come and be a part of a group that thinks through, okay, how do we take all the things you know and expand those or make them into a system? And so in the Oral Health Project, part of expanding children's preventative oral health has been tapping into Greater Portland Health and mainly Teeth's expertise and understanding of what it takes to do it. And so the project paid them, we had ARPA funds, to pay them to bring their expertise and the ingenuity they already are using to expand their services in schools, but doing it then to really be able to inform how to make a system, that uses what they already are doing. And I think doing that's funding relationships in some ways, right? It's funding people's ingenuity to bring to the table. And we've seen it, and I think our role then is facilitating convening, right? It's not like we don't do it. Like the people who know how to do it, we're supporting them to do it. So I think that's how I see tapping into that kind of local knowledge and local efforts that are well underway, but are done in little tiny mini silos.
Got it. Thank you. Morgan?
Sorry. So I think Carol knows the story that I'm about to tell, because I've told it a million times, and she's probably heard it half of those million times. So I'm a big podcast listener, and I heard a podcast last year about a community in Vermont, and there was a nonprofit organization, they called it the Civic, and they just sort of did civic projects in their community to get people together and do some community engagement. Well, someone came up with an idea of doing community dinner theater and writing the whole play as a community, and having the VFW do the spaghetti dinner and selling the tickets, and all to benefit the community. And all the actors, they helped write. They were also it was the town manager, the fire chief, the principal, all these people in the community participated in this project. And people thought they were crazy, and who was going to go to this silly community dinner fair? Well, you couldn't get a ticket. It was the hottest show in town, and they sold out 3 nights in a row. It was a huge success. People had so much fun doing it, and I remember the town manager actually played the town manager, so it was it was very mirroring, and it was great. And a week later, Vermont had catastrophic flooding. Catastrophic, and it was so unbelievably destructive to people's lives. But that community, they knew how to work together. because of that project they had done together. So they knew how to mobilize, they knew who to call, they knew what they needed to do to support their neighbors. And so it's funny, it just occurred to me listening to both of you talking that what a piece that funders could support is relationship building through joy. So we should really be funding opportunities for joy so that communities get to know each other in that way, and that so we can overcome the division that has been created by all of these terrible systems that don't work. You know? So I guess that's kind of my perspective, and I tell the story about that podcast. And if you want to look it up and listen to it, it's called The Rumble Strip, and I think it was the title of the podcast was something about the 100-year flood or something like that. So have a listen, and I'll also say that's not unique to Vermont. I mean, there are things happening all over the state of Maine that replicate or look exactly the same. And from even my perspective, the coalition work that I do, and part of that is we have something called the Funders Advisory Board, and the acronym for that is FAB, which, so we love saying that we're getting the FAB together. And it's all about oral health transformation, and we have a bunch of different funding partners who are part of that work, and we've been doing it for several years now, and we plan to keep doing it for several years. And the thing that keeps me at that table, I have to be honest, I mean, it's great work, and I love going to the meetings because they're fun. Like, I love being with my colleagues and engaging in that, and it just feels vibrant and joyful. So I think funding joy is the answer.
I'm so glad you told that story, Morgan. Thank you. That may have been a setup. But it also, I want to say, I do a lot of communications work, and I wanted to say that I can guarantee many of you will remember the story and keep hearing it in your head, right? The idea that you can actually get stuff done by convening folks to do a play is really important, right? And so the power of storytelling, this is a lesson within a lesson, right? But the power, for us, the power of storytelling is it doesn't have to be your own story. You can actually share a story. It has dialogue, it has, imagery. Stories are super powerful and they're worth investing in. So I would just use that as an example of the power of storytelling. You can all email me like a month from now, tell me if you still remember the Vermont local play story, because it just has stuck with me so much. So thank you, Morgan. I would love to turn it over to you all and hear if you have questions or thoughts or additions. Just ideas around things that are working really well, assets that are out there that we're not taking advantage of. How can we do more to build infrastructure, to build systems, to actually create the space where oral health equity is a thing, and we get there in our lifetimes. Anybody have any thoughts or inspirations as you've been hearing the conversation? Questions? Yes, Rachel.
So I just have a comment and then a question. My comment is actually around the state isn't doing anything, and I know that's not what you
That's not what I said.
Okay, because I just want to draw a little bit of a distinction between, and I love the emphasis on the local and the micro, but the distinction with the state is that the state is supposed to use public resources for the public good. So you need a combination of both. You need both the alignment at the local level that's focused on the targeted universalism, but you need the state because that is in the public interest. So I don't want anyone to be confused that the state isn't a necessary component, particularly around policy making and investment.
And I'm sorry if that was the message that I put out, was that the state is 100% necessary. There's just things that the state can't do.
That's absolutely yes. It is an actor that's important in thinking about this. But my question is really to each of you around, we keep using this word community, and community is the investment, community action. And my question is around a community that I come from, which I will call a historically generational African-American community or population in the state of Maine that was here before statehood, that derives a lot of its history out of enslavement. community has more built environment in the state, and it's actually quite invisible when we talk about brown and black communities. It's not the first thing people think about, although we've been here for hundreds of years. So my question to you is, how do you do asset building for a population that has the generational transference of poverty, has a history built in enslavement, has no social infrastructure, has no built environment in the state, and there are not any funders who are thinking about that specific population in an equitable way, the way that you all have defined it, because it has no known unity, it has no neighborhood, it has no city, it's not identified in any particular way. How do you help that community with investment and local asset building when there's not a uniform group of people to naturally build a coalition with?
Thank you so much, Representative Telly-Ross. Really appreciate you being here as well. I'd love to hear what the panel thinks. And then before you start, though, we'll just do a time check. We're at about 5:11.
Yeah, you got another 20 minutes, 25 minutes.
25 minutes? Okay.
22 minutes.
22 minutes.
21.
Okay.
Thank you for that. And, I hear the pain and the passion in your voice when you speak about it. In some respects, I think you are part of the answer, right? It goes back to me to talking about the assets, right? And instead of looking at things from a deficit standpoint and talking about what all we don't have, right? What do we have? Who is the voice in that particular group of people that can bring people together, that can bring information to people, that can highlight, and has the courage to stand up and let other people know what's going on. When we got this contract from the state to do Type for Life, right? After we got the grant, we realized that there were still some cultural differences that even our front funders still didn't understand. Their particular view of what a beauty and barbershop is in the community was very different than what it actually is for us. And they didn't ask us to describe the layout of the beauty and barbershop. They didn't ask us to describe how salons run, right? They didn't ask that. They took their preconceived understanding of what happens in the beauty and barbershop and what that layout looks like, and based their answers and their thoughts about how we should be doing the work based on their experience, not ours. So, for one, it's important that we identify local champions within the community, and every community has them. They might not, be polished, right? They might not have the skills, but if they have a voice and the passion and the trust of the community, you have something there. So we have to build on that. I also say, because this is an election year, right? We have to stop telling people that you gotta vote and just leaving it there, right? Where's the pre-work? Why haven't you been helping people to understand why their votes matter beyond saying, because your ancestors died? Give me a break. It's not gonna get it, right? So building upon the assets that you have in the community, really diagnosing and dissecting from the community standpoint about what assets you have and how you can build there. And then, of course, please, if you are a person of color, please get out of the closet and start running for some of these elected positions. And you don't have to be a person of color to stand up them to stand by and support a person of color who's running for an elected seat. And Lansing is only an hour and 15 minutes from Detroit. But when I say most of the administrators there have never been to Detroit, it's the truth, and it's ridiculous.
Representative Ross, I really appreciate your question and the framing of the question as well. And I think that I've been thinking about it a lot about like what is community? And I think we've had lots of discussions in our conversation about infrastructure, and that there is geographic community, there's demographic community, there's communities that are created through organizations around activities, and that I think my definition of community is broader, but when we speak of community, often people go right to geography. And so I think there's a broadening of how do we talk about it, so that we talk about community in different ways. And I think, and I've been thinking a lot about how do we support, or how do we work with and find out what people want from us in government and what is needed for us to support their endeavors and efforts. And I think of places like, and you know, we'll admit we're still like figuring out what do we have to offer, like what do we bring to the table, so that we are coming with bringing, you know, humility and a desire to learn, but also like perhaps hopefully coming to the table with other offerings as well. But I think of organizations like Indigo Arts and The Third Place, who are organizations that are doing work to advance the well-being of historically marginalized African American groups here, and what is it that we could be doing to be either in partnership or amplifying the work that they do. And so, you know, I mean, I think that's how I'm thinking about it, and also am very open to this being a conversation of how do we continue to support groups that feel like they don't have community and space.
Thank you, Lori. Okay.
Thank you for that question, Representative Talleras. And I think it's from a funder perspective, you know, especially for Bingham, as we're thinking about supporting this community hub work, the first question that I think our community partners need to ask is, who isn't here? Who is not at this table right now? And how do we find out who those people are, and how do we get them to the table? And I know that's kind of an overly simplistic answer, but I think just asking the question, and as a funder requiring that people ask that question as part of the process, and designing a process that is more inclusive, because we know that those tables will only be stronger with having all the community members represented around the table. And I don't think that totally answers your question, but I hope it answers part of it.
Thank you. I'd love to hear if folks have anything to add to that in terms of, you know, what can we build? I love the targeted universalism concept, and I'm looking forward to reading more and getting a better understanding of that, but this idea that we're building something for everyone. And so is there a way that we can be doing that in this case? But anything you want to add, so it can be on that topic or another. Yes?
Yeah, I'm Kathleen Miller. I work for representing Maine. I'm CHW primarily for the Spanish-speaking community. But I wanted to add that I think that I'm not a native Mainer, but I do work with the Latinx community. We don't see very many Black American community members, but there is a huge gap, I think, with Black American people, and they're not being really represented in the state. And also with the Spanish-speaking community, it's really hard for them to access dental care because we are a patriarchal society. But if you kind of like dissect it a little more, you'll see that it's really like a matriarch because the mothers will push their husbands and stuff to get the dental care, to get the medical care. They'll put everything in front of themselves before getting help for them. And so I think as the policy makers and stuff, we do have to like kind of dissect things a little and see that transportation is a big thing. Like the mothers will push the dads and the children like they can get things done for themselves, but the mothers will have to rely on like me, for example, to give them the transportation because not everything is inclusive. I've had a lot of mothers who ride the bus or ride like Nana and they feel so ostracized because they're the only person in the van that doesn't speak the same language as everyone else. And so then that's where we see the lack of care and dental like stuff for the mothers I help. And so they're like, well, I don't want to ride the bus. I don't want to do this because I'm not represented in all these spaces. And neither is the Black American community because like we don't really see them and we don't really talk about them. We're concentrating on other populations and we're missing I don't know if it's a big one or a small one, but we're missing a population that isn't being fairly represented as someone, like you said, that was here first with also like our Indigenous population here.
Thank you so much for that. Thoughts from our panel?
You know, when you talk about that, you know, it is like you can't understand it until you've walked in those shoes, right? And it doesn't have to be a language barrier. It can be, you know, lack of hearing. I never, you know, even thought about the difficulty people have in spaces like this or large conferences in, you know, hearing what's being said until I realized that I needed a hearing aid, right? So walking in other people's shoes is so important. It requires some sensitivity training on everybody else's part, right? And then really understanding from that person or that community what their challenges are. A couple months ago, we were looking to do a project with mothers who are pregnant and currently smoke. And we gave them stipends and I'll cover their transportation and all of that for them to come to us for the reasons that you spoke about. Well, when it's time for the mother to go back and she had 2 small children with her, I called the Uber and the Uber driver told her that she couldn't get in the car. And it was because they didn't have a car seat in the car for the 2 small children that she had with her. Crazy, right? I wouldn't have thought of that. But it really does require, you know, having those voices at the community. What you're speaking about, I wouldn't have known about unless you told it to me. So we have to continue to have the conversation and raise the visibility. The other thing that I'll say, and it kind of ties back to what you said, you know, food for thought for our funders and grant writers. Years ago, the Kresge Foundation was in Detroit and they were providing funding, right? If the funding is really supposed to be to support the community and it's supposed to go directly to the community, why do you make it so hard for people to access the funding? Why do you say you can't use it for construction, you can't use it for equipment, you can't use it for food? Well, doggone it, those are the things that we need. You want folks to show up for free? You know, without daycare, without transportation, after school, after work, and there's no food available, why would they do that? You know, so, identifying those additional resources, those unrestricted funds that can support those things, and then identifying the people in the community that are already doing the work, and not asking them to do additional work so you can check off the box to who you have to answer to. Fund them to do the work that they're already doing. We provide $5,000 mini grants to community-based organizations. There are 10 simple questions. It's not a long, extensive application. People shouldn't have to go through a whole lot for $5,000. But $5,000 can go a long way. It can provide the transportation, the food, the stipends, the things that people need to be able to participate in a meaningful way that will amount to systematic changes necessary and impactful and needed for communities of color.
Could you just, do you mind, Liz and Maureen, do you mind? Could you just say, where does the money come from that then becomes the $5,000
Yeah.
How
So
do you pool that?
when we negotiated our contract, we do get some funding for Campaign for Tobacco for Kids. So when we negotiated our contract for Campaign for Tobacco for Kids, I asked for part of that money to be allocated for immigrants. You know, and it's because the churches, I mean, we saw it during COVID. Right? People were scared, they didn't know what to do, there was no system in place, but the grandmothers, the churches, the block club people, they were finding the mask and the sanitizer and learning how, you know, to do the test and providing shelter. They're already there doing the work. It might not be organized in the systematic way that people have wanted it to be done. But if it's really about bringing the funding and the resources to the community, make it so that they can access those resources. I mentioned Kresge in the beginning because when they had funding that came out, they allowed an opportunity for communities to apply with a video.
Nice.
So you didn't have to be, a seasoned grant writer. My organization is still considered small. I don't have $7,000 to pay a grant writer on a baby. I don't have it. You know, so I think we need to look at those things. And then I'll say, your example in Vermont, bringing community together, and raising those unrestricted dollars, right? Those are examples of ways that you can really pull in some of those resources that you need to buy a van. Put it on the list and make it known. There are philanthropic organizations, and funders that will support that. But you have to put it out there and let people know.
Thank you. One of the things that you said to me last night, which I thought has stuck with me, has been keep a wish list. Just because you didn't get it this time doesn't mean you don't want to keep putting it out there, whether it's the band or anything else.
Yeah.
I want to, convene a group to do a play.
Yeah.
Anything, 1 minute from?
Yeah,
from
well, I
each
just
of you?
wanted to add that I think to your point around meeting the needs in many ways of what comes up, I think is where right now there are so many organizations and like us too, I can see what all these things are and all these needs are, or places where we could be having deeper conversation to figure out how could we be working together. I think this is for some funders in the state, we get funded to do programs. We all get funded to do programs. And we aren't funded to build our capacity to do the relationships or pay folks to show up and have their needs met, right? It's really hard to get that kind of flexible funding to do that work. And I think what I hope is that we continue to have this dialogue that can be community or community-based organization direct to the state, or can it also be through other regional organizations like ours where we can say, hey, we need oral health navigators, right? We need folks who can support people to get to their appointment, and it needs to be culturally and linguistically relevant for these groups, right? I think that's where we have to, how do we come together to keep advocating for that really deep capacity that is not a program.
Thank you, Liz. Maureen, do you have anything? 1 minute?
Yeah, I'll just add to what Liz said, which is exactly the infrastructure that we don't currently have in counties around the state. And so what Liz has done in Cumberland County is totally unique in the state. There's nothing like it. There's no other Liz. I mean, there are Liz's in other counties, but they aren't resourced in the way that Liz is to do this work. So that's, what I was talking about earlier is exactly this. So how do we create the infrastructure at the local level to make sure that folks have the resources they need, so that when someone comes and says, we have this, we have a van full of folks and we have a person who's not speaking the same language as others and we need a translator, or, that those connections are able to be made in a systemic or systematic way, so that people aren't left feeling hopeless and like there aren't resources.
Thank you. So I would love to, there's 3 minutes left. 2 minutes left. All right, I'm so sorry, but can we, 30 seconds, and then maybe try to put out stuff that we can have side conversations afterwards?
Sure.
Okay.
My name is Nelly Delberg, and I'm Rachel. I don't know where she. Thank you for being here, but I think it's important. I won't be able to go to bed if I don't say what I need to say. And I think it's great work. It's happening in the state, but still, there's so much to do. Communication between the state and the community-based organizations and the public health sector, and all community members that they know what is the problem is, that there's so much work that have been happening in the state of Maine at the local levels, that we come up with our own strategies to survive. Like my program has a big coalition that we have over 200 members that we pull from each other, from our own resources, because we don't have help. Sustainability is always a problem in the state of Maine, and this needs to change because the state needs to work with us. Rachel, I just learned yesterday about the HB 1252 that is looks like is the data program from the state. That's a great resource that many people didn't know about it, and data sharing is a problem. We need to know what is going on around the state, what your organization is doing, because we don't have resources, we don't have funding. Sustainability is always a problem. We can get funding from 1 or 2 organizations, but then the funding ends. We are right now, September, all COVID funding is ending. Many of us, I don't know, very concerned, what is going to happen with my staff? That is a stress for program coordinators or directors, and that has to change, so communication is so important and needs to happen. Like inequity has to be prevented in our work toward equity, because there is so much, like, I always forget your name, Kathleen mentioned, the Latino community, African communities, they're not represented well. So we can serve, we can do some work, but if we don't have inclusiveness and equity within our work toward equity, that's not going to take us to others. That's it.
Thank you so much, Lee. Really appreciate it. You all are amazing and do amazing work. So I would like to take the last -1 minute. I know 2 folks had their hands up, but we don't have time for that. But I would love to do a word cloud without the cloud, which is just, if you could add one thing, maybe it's that magic wand, but if you could just add that one thing of infrastructure or systems that you feel is missing, I would love it if you would just shout that out, and then I'd love to connect with the 2 folks that had their hands up and just make sure we integrate what you said. But just, what would you add? Like, if we
Student loan forgiveness for dental hygienists and dentists.
Love it. Anything that just feels like such an obvious.
Transportation accessible in languages other than English.
Nice. Thank you. Anything else? What's the dream? Systems and infrastructure.
Dental therapy.
Dental therapy. All right. Thank you. Thank you so much.
White people.
Oh, hold on.
Less white people.
Excellent.
All that unrestricted funding.
Unrestricted funding. Yep. Relationship building funding. Relationship building with joy funding.
Yes.
Good. All right. This has been, speaking of joy, a joy to be with you all. Thank you so much for your attention and your engagement. And thank you to our panel. You guys are amazing and just really appreciate everyone in the room and all the good work you're doing. Looking forward to the rest of the day. Thank you.
I just want to once again thank the panel. Sorry, can you hear me? Oh, yes. I just want to again thank the panel for all of their insights and all of the questions that were asked. We are going to take a 10-minute break, so we'll see you back here at, I don't have a clock. But you guys are smart people and you'll know when 10 minutes is up.
I think
enjoy the wonderful panel. I hope you're able to take a little bit of break. You were able to enjoy some breakfast. I got a couple announcements before I introduce our second panel. Very excited that you're here. And so just a couple announcements. One, we have a slide up here. I already had a slide up here. Cross-Cultural Community Services is going to be offering a four-part training series beginning in October. If you want any more information on it, you can scan the QR code on the our so-called screen, or you can our man-made screen, or you can go to our website and click on the training tab, and you get all the information on our upcoming training. So that's the first announcement. The second announcement is we have Maine Care here. We're very excited that they're here. They have a table over there. And so there's a lot of information over there on Maine Care in general, on oral health. So please stop by and talk to our folks at Maine Care, because they have a lot of information and some really, really cool, what are they called?
It's like an ice pack.
An ice pack swag, sorry. They have a lot of swag. So please go over there and visit our folks at Maine Care. My third announcement is we really want to hear from you. And so, not today, but if you're willing to, not today, but if you're willing, we would love for you to sign up to have our communications person give you a call so that you can give us some feedback on how today went for you. And so if you're willing to talk to Warren and give him a couple of minutes of your time, that would be great. You can go and see Tony and give her your email address or phone so we can follow up. So those are my three announcements. Now, on to our panel. And so I want to welcome our panel. They're going to be talking about really what's happening in the state of Maine regarding public health and oral health, what they're doing together, how they're collaborating, and all that good stuff. And so we have Kate Christensen from Maine State CDC. We have Courtney Platson, who is from the State of Maine Maine Care. She's the director of Maine Care. Medical director. I'm sorry, I downvoted you. We have Becky Madichovitz from Children's Oral Health Network, and of course the lovely Kathy Ray Del Rio from BJ. And so I'm going to turn it over to you, because nobody wants to hear me.
Thank you. Can you hear me? I'm not used to this. Thank you so much, Regina and everyone today. Just quickly, my name is Kathy Del Rio. I use Student Programs. I'm the Advocacy and Programs Director at Maine Equal Justice. I am not an oral health expert. However, I did help work to secure an adult dental benefit in the Maine Care program here in Maine. And then we'll talk more about that, but as part of that, I also have had the honor of serving as chair of a Maine Care Advisory Committee subcommittee on dental care for the past several years, and it's just been an amazing space where I get to learn a whole lot from people who actually are experts, like some of those here at the table today and in this room. So really appreciate that. And we're really coming at this, I think, from a little, from a perspective around policy, around some of the bigger systems that oral health happens within. And so that's where we're going to try to guide the conversation through today. Obviously, there's so many pieces to trying to figure out how we can have more equity in oral health. So we're going to start off by just asking everyone here today to introduce themselves and give us a little sense of what your role is and how you're connected to this issue. And we'll kick it off with Courtney.
Good morning. My name is
Hello? There we go.
My name is Dr. Courtney Platson. I am the Maine Care Medical Director. I also am a family medicine provider. I work at Greater Portland Health and Healthcare for the Homeless Clinic 1 day a week, around lucky enough to work alongside our dental team and dentists here. I want to give a shout out to the amazing dental team at GPH. I oversee our dental benefit for Maine Care and have been deeply appreciative of the amazing work and the coalition building that has happened around dental and oral health care in the state. I also just wanted to, when I think about equity, it feels important to think about the lens in which I look at this issue and challenge, and thinking about how it identifies with my own story. And I just wanted to share, I grew up experiencing poverty, and I experienced homelessness as a young child and as a teenager, and I was on Medicaid my entire childhood and into adulthood. And I had the frustration that I'm sure many people can identify with of, in the state that I grew up in, dental benefit wasn't seen as, as a necessity. And so some years when the state budget wasn't great, dental benefit got cut. And the next year it might be turned on, but the year after that cut. And so I had intermittent dental care and eye care my entire childhood, which now, even as adulthood, as someone with a lot of privilege, I now have, awful dental issues related to my childhood. And so just the framing that oral health care is seen as dispensable, it's not essential, we can just take parts of our bodies saying like this isn't essential, is so problematic. So I just want to say from an equity standpoint, access standpoint, really trying to change that and seeing oral health care is so fundamental to our overall well-being and being our healthiest selves. So I just wanted to name that a little bit and share a little bit about my professional and personal connection to this topic.
And Kate?
Hi everyone, I'm Kate Christensen. I'm the Oral Health Program Manager for Maine CDC, and I am tasked with rebuilding our state oral health program, which many of you know has been a little bit non-existent for almost a decade, but we did still have some initiatives such as the school oral health program still moving forward, which is great, but my role is to essentially bring everybody together and help drive all of these issues that we're talking about today. I'm also an independent practice dental hygienist and have next year 20 years of dental experience, which is more than half my life. And like Courtney, I grew up in situations with disadvantages, homelessness, and food insecurities. So I come with that lens and also the lens of a provider from the LGBTQ community. And very passionate about this work and really excited to be here today.
Thank you. Rebecca?
Good morning. My name is Becca Matisovich, and I'm the Executive Director of the Children's Oral Health Network of Maine. And unlike Kate and Courtney, I do not have a clinical background at all in oral health, but my lens also comes from being a child with lots of dental disease. I think I had a cavity in just about every tooth in my mouth by the time I was probably 8 or 10. And although I was very lucky to have access to dental insurance, access to dental care my entire life, I don't think I missed a 6-month cleaning until COVID actually. I had a mom who worked in public health and we had access to the services, and I still had a cavity in just about every tooth in my mouth in spite of that. And so I grew up with a lot of empathy for how difficult it is actually to protect your oral health even with some of those benefits, and really a sense of shame, understanding how it really hits, and that it isn't just brushing and flossing, that there is a lot more to it than that. It isn't just going to the dentist. And so, so that has made me sort of very passionate and understanding that anyone who lacked access to the care I was able to access would have been in much worse condition and had much more disadvantage in terms of being able to protect their oral health. And so I knew that if it was that bad for me, it was really inequitable.
Thank you all. And while I'm not on the panel, we planned a little bit for this, and I'm going to take a few moments periodically through this to add a little bit from my perspective. I mean, equal justice first question. I think everyone in the room, or most of you at least, are probably aware of the fact that our healthcare system in the United States is deeply flawed. And it was, as was mentioned earlier today, definitely not created to serve everyone. And it does not serve everyone in so many, many ways. And one of the big ways that it doesn't serve everyone is that from the beginning of healthcare systems, dental, along with vision and hearing, have often been disconnected from the rest of our healthcare, as if our mouths and our eyes and our ears are not essential to our well-being and our way of moving through this world. So that's something that we've had to overcome. And I will say, I think one thing that has happened in recent years is that finally it does seem like the message is getting through to policymakers and to both at the state level and nationally, that our mouths are part of our essential health care. And so there are a lot of moves forward. But just to give us a little perspective, some of the progress we've made historically, I wanted to mention, for a long time, health insurance was only available to people who paid for it. Then in 1965, we passed the Medicare and Medicaid Act that created programs that were meant to help people with lower incomes. However, Medicare, to this day, still does not cover oral health care. And that is a program that people who are older, people with disabilities, often access for their care. And if you want to be able to access oral health care through that program, you have to purchase additional health care, which is often inadequate as well. And then Medicaid, which is a federal program that is run differently in every single state. So there are lots of different state options for how we run our Medicaid program, which serves low-income people. And that program gives states the option of whether or not to cover oral health care for adults. And it requires that they provide oral health care for children. We made some further progress in 1997 when we passed the Children's Health Insurance Program and expanded health insurance options for kids who were a little higher income, weren't eligible for Medicaid, but still needed care. And that also includes access to oral health care. Those we'll talk about, often children may have that coverage, but still not be able to access that care. And then in 2010, we passed the Affordable Care Act, which made changes in the marketplace, sadly not including oral health care specifically. But one of the big changes it made, it also expanded eligibility for adults with low income. You didn't have to just be an older person, a person with a disability, or a parent or a pregnant person in order to be eligible. You actually could be eligible up to 138% of the federal poverty level, regardless of whether you had kids or what your age was. And that was a huge change. But here in Maine, sadly, we did not adopt that. And some of you who've been here for a long time know that we 5 times tried to expand Medicaid in the state legislature. It was vetoed every time by former Governor LePage. And finally, it was brought to the ballot box where overwhelmingly voters supported passing it. And that was supposed to go into effect in 2018. Governor LePage still refused to do that. So it wasn't actually implemented until Governor Mills came in office in 2019. But since then, we've covered over 100,000 adults who would not have had health care otherwise. And in particular, that was essential during the pandemic. But it also provided people access to greater healthcare options. However, at that time, it still did not include dental. So if you were trying to access oral health care as an adult, your options were really limited to paying out of pocket or waiting until whatever was happening in your mouth was so bad that it was an emergency and you go to the emergency room or to a clinic and they help you with that emergency. And it created much harm on people's health, not just their oral health. But we introduced a bill in 2019 to try to change that, and a whole coalition, for the first time, I think, it really had a strong, robust coalition of people who were focused on children's oral health, even though we're talking about adults, recognizing the importance of parents having access to that care. It had providers at the table saying, yes, we think this is important too. And it had low-income people who were directly impacted, sharing their stories. And that bill didn't make it over the finish line. We came back in 2020 and we're very close to getting it over the finish line, and the pandemic struck. But then, in 2021, we were able to finally pass it. And that went into effect in 2022. And I'm going to wrap up in just a second, but I did just want to name a couple other important moments in terms of equity. So one thing I'll say is I personally, I think, have been one of the best examples of state government working collaboration from the beginning of trying to implement this benefit, and continues to be a collaboration today. And then I also just wanted to name a couple other quick things, because even with Medicaid, we still don't have access for everyone. So immigrants are often excluded from our healthcare system because of their immigration status or because they lack documentation. Here in Maine, interestingly, back in 1996, when the federal government excluded immigrants from a lot of federal programs, Maine continued to cover people. And I asked advocates who were here at the time, why do you think we were able to continue to do that? And they straight up said, like, I think because most of our immigrants were white, like they were from Canada. And in 2011, things had changed, right? We had a very different population of immigrants coming into Maine. And Governor LePage was able to use that and use a lot of racial attacks to cut access for immigrants who had access to Medicaid before that. Even when we still protected some access, there were still people left out, and we're trying to change that. But we still haven't fully undone those cuts that Governor LePage did in 2011. And so, while we have managed to win back coverage for kids under the age of 21, regardless of their immigration status or lack of documentation, and for pregnant people, we still have to figure out a way to continue to cover adults. But with that, we've also been able to include kids in expansions to the Children's Health Insurance Program, and it's a huge sea change in terms of access for that population. So I just wanted to name a couple of those things as we think about, like, where are we in terms of coverage? Obviously, coverage in and of itself does not mean access, but that's just an important piece of our framing for us. And so that's a little bit about where we are, Becca. Can you share more about why the Children's Oral Health Network was created and how it fits into this current system of oral health?
Yeah, and I think that's really helpful history, and home sort of like fits right in midstream in the middle of that history, building on all of those efforts and many others along the way, and sort of picking up on that theme that coverage is half the battle, and we've made a lot of progress on coverage. As we have seen that progress, it has become more and more clear, I think, that the system was never designed from the beginning to serve all people, the dental system, and many other systems as well. But talking about the dental system today here. And if you think about what the dental system consists of, built largely on private dental offices, designed to provide services to certain groups of people who can pay out of pocket for their care, or people who have an employer who provides dental benefits that help defray the cost. People who live close enough to a dental office that's taking new patients, who have reliable transportation, people who speak English and can call for appointments easily, people who have a flexible work schedule and can schedule appointments, often required to be scheduled 6 months in advance, and know that you have enough control of your work schedule to be able to keep that appointment when the time comes. And largely people who grew up with care, understanding sort of how dental offices work, comfortable with dental providers and with people's hands in your mouth, which not everybody is. And so this is actually, when you think about it, a relatively small portion of our population, probably, that the system was really designed to serve. And there are also, of course, important organizations that were created as sort of, I'm using with quotes, safety net organizations, right? And the nonprofit dental centers that are doing awesome work, and federally qualified health centers that are, the dental programs that were created to help fill some of those gaps. But I use the term safety net in quotes because it doesn't seem like we should have one system that is like the regular system that's designed to serve some people, and then the safety net system that is designed to just fill gaps for the people who fall through. So we started kind of rethinking, and HOME was created really to move this thinking along, to pick up on sort of what is the delivery care model, or models that really could work better than this traditional system. And the other aspect of this is that we're talking about a disease that is infectious. It's caused by bacteria. There's much more scientific knowledge than we knew in the past that bacteria spreads between people. often in households and families, and if we aren't providing care and access to care for the whole family, bacteria spreads. That's just the way it works. It's also a disease that's chronic and progressive. It's going to get worse if intervention isn't available to treat the disease. But it's also preventable and manageable. And we have many more tools now than we used to have to prevent it and to manage it. But the system, which was only designed to serve some people, was designed to keep those tools behind locked doors. And so that inequity is right there in the design. And maybe some oral health equity work is about helping to open those doors, helping to get more people the keys to those doors. But some of the equity work that we're doing is actually designed to bring the tools out from behind the doors and bring them out into the community. So it's probably enough for now.
Thank you so much for that. And Courtney, when we think about oral health equity, what's the role of Maine Care?
The role of Maine Care is massive. Maine Care is the payer for almost one in 3 Mainers and 1 of 2 children. And every 50% of children, Maine Care is their insurance. The problem, though, is something that Becca spoke to, is having the insurance doesn't equate to accessing the actual clinical dental care. And so part of what we're trying to figure out within Maine Care is how do we recruit more providers? How do we not only recruit more providers, but recruit providers that want to do this work equitably? So my concern is I don't want everyone to sign up for Maine Care that isn't going to provide culturally responsive care, that is not going to actually help address some of the barriers. I don't want people to sign up that are going to provide stigmatizing care or continue to cause trauma in certain marginalized populations. So we want to partner with dental community to increase access, but we want to do it at the pace of trust and really help to make sure that they have the right training to be able to provide great care. The other piece that feels really important that I want to name is that system change happens with people within the system making incremental progress. Within, for example, my role in state government, it happens with advocates outside of state government, like the role of many in this room, pushing the state and pushing Maine Care to do better. And it takes people to be visionary and dream of whole entirely new systems, because that incremental progress is made on inequitable systems. And so it's important to understand where you fit into that trifecta and to think about what your role is in helping to improve the system overall. I will say I'm more comfortable as an advocate than I am in state government. I am new to state government. And because I provide care every single Monday at the Healthcare for Homeless Clinic, I see the barriers people have. I see for people who English is a second language, for people who are homeless who have almost no teeth left or rotted teeth, the difficulty of getting a job because you have poor dentition. So many barriers that poor dentition has created for people that impact on mental health. And so Maine Care has a huge role, but I also just want to say it is a piece of it. It can't fix all of it. Anytime we have something at scale that's providing care to over 366,000 people, it's not going to be perfect. And so we need to make sure that we have advocates that are pushing us and people like you telling us where the system is inequitable. So for example, we have motive care. We have non-emergency transportation. I'm sure we could do a whole day on how challenging our non-emergency transportation system is. Medicaid has a role in trying to address health-related social need, and anytime we try to help every person in every corner of our state access health care, if we have people in corners of Aroostook County needing to travel hours to get to a dental appointment, and if motive care is late, they're gonna miss their dental appointment, and they just wasted 4 hours of their day, and their day off, and their child care, just trying to get care. So the challenge is when we, as a state government, are trying to think of how do we provide care to everyone in Portland, and Aroostook County, and Franklin County, we're gonna be imperfect. And so we need your help to tell us what we're doing. I'm going to talk about, I think later, some tangible ways that we're going to try to make improvements. But one thing I just want to say, that I can't tell you how many times we put forth section of policy changes with no comment, with no public comment. So, for those that aren't aware, our requirement at Medicaid, at Medicare, when we make any changes, proposed changes to policy, we have to have a 30-day comment period. It is federally required. So any policy, any rate change, we have to open it up for public comment. I need you as advocates and the community members on the ground to submit public comment. I'm going to give you one small example, and this is targeting equity specifically. We're opening up our targeted case management section for public comment. In currently our targeted case management section, you have to have a bachelor's degree to provide case management. How many peer supports and community health workers who are absolutely amazing, moving mountains for our clients and members who do not have a bachelor's degree? That is an equity issue of requiring a bachelor's degree. I need folks to comment on that. And that's one small example of equity. How many folks come from other countries who have doctorate degrees but are not recognized as bachelors in this country? So I need you all to tune into public comment. We need you as advocates. We need your stories. We need your voice to make our policies in the state better.
Thank you, Courtney. And just as an aside, if you are not familiar with the rulemaking process and would like to learn more, please reach out to me anytime. We often do engage in rulemaking at Maine Justice and are happy to help other people learn the process and how to do it.
Can Courtney send the link through services, so she can share with everyone so we can look at it?
Yeah, the request was could we make sure that the link gets shared with everyone who's here today when that rulemaking opens. And Kate, what do you see as the role of the CDC in how to equity?
Yes, so like Courtney, state government is a little bit different in how we function within our means and bounds, but it still takes a village to work together. But for the role for Maine CDC, number one would be data collection and analysis, and gathering and analyzing data on these oral health disparities, and identifying these populations where these disparities exist, which we already know. However, there's another piece of it where we start to assess the effectiveness of interventions and how we can increase the oral health status. Another example would be public health programming. At the Maine CDC, we have a Maine CDC school oral health program, and semi-recently, back in 2022, they changed the rules for who is allowed to participate and enroll in the program. So previously, schools that had a 40% free reduced lunch rate were the only ones that could participate in the school oral health program. Since then, that barrier has been removed. It is now open to all schools, all grades across the state, which is a huge win. So leading into how we can work together with public health programming. And that leads me into our partnerships and collaborations. And especially with rebuilding the state oral health program that has been absent for quite some time, and knowing the need, this is one of the most important pieces, I think, to this puzzle, is really leaning into these collaborative efforts, working to catalyze each other's efforts, not duplicating efforts, because we know across the state our resources are very few and far between. So how can we work together to collaborate between local and state organizations, schools, higher education, CTE programs, healthcare providers? And lastly, still talking about education a bit, is providing more educational resources, not just on increasing the awareness about oral health, but also thinking about our workforce and how we can create pathways into our oral health workforce and diversify it. Because everybody should be represented and everybody should be able to go into an oral health care setting and see somebody like them.
Thank you so much. So obviously it's really important for us to have a good understanding of the data in order to understand where are those disparities, what do those disparities look like, and also what type of progress are we making to address those disparities. From your perspective within your own roles and organizations, what does that data collection and use look like? And Courtney, why don't we start with Maine Care?
this is a fascinating challenge, and I spoke to Carol about it actually at the break. So a few things. I can't tell you, so the data that I'm looking at from health outcomes data, from Maine Care data, I can't tell you how much information we get from claims that does not have race and ethnicity data. We can't track and measure improvements in health outcomes if we are not collecting that data, and we know that data does not tell the full picture. Part of the challenge when we're reporting information to the federal government, there are many things that we actually don't submit our race and ethnicity data because the N is so low. And my concern is that that those are inaccurate because we have healthcare staff that don't feel comfortable or don't have cultural sensitivity training, don't have the training to ask those race and ethnicity data questions to patients. They might make assumptions based on how someone appears, which is completely not factual and not help, is problematic. And data is wholly inaccurate of being able to describe the problem. So I really appreciated, I forget your name, the community health worker. The story that you shared is so important. And that's one person's experience of one mother and a family. So for me, what feels really important is taking the data, getting more accurate data, and pairing it with storytelling. If we are relying on data alone in the state of Maine, that's the whitest state in the country, it's going to be very difficult to move the needle. If we're pairing it with story to help articulate the barriers for people, to help identify strengths and resources and assets, the storytelling is going to be essential. Because even in a picture, when we're looking at 96+% white, 4% people of color, it's so skewed, and what we can do with that data is so limited. So I just want to say, one, we need more diverse healthcare staff that train the healthcare staff that we have to get more accurate data, and then B, really be able to articulate it with storytelling, to be able to do that to funders, to report to the state, so we can share that with the federal government, to really be able to get at what Liz shared earlier about the targeted universalism. There was one other piece I wanted to share about the data. But I just want to share, this is an area for me. We hired a health equity data analyst within Maine Care to help us get to this level of detail. The one thing I wanted to share, and I want to tie this to a specific example, and this example I think many are aware of, but when we started in the very early days of COVID, when certain communities were disproportionately impacted, we wanted to have a health equitable outreach strategy to get vaccines to people, to communities that were disproportionately impacted. We knew that communities of color were having higher rates of COVID infections and having higher rates of illness. But the problem is that because people weren't collecting race and ethnicity data with vaccinations, we had no idea to track if vaccines were getting to the affected communities. So we can't actually create equitable responses if we're not collecting that data. We can't even track and actually be responsive. I just want to say that there is a specific corollary to collecting that data to have targeted public health interventions that are trying to have some protective factors for disproportionately impacted communities.
Thank you, Courtney. Just to add to what you were just saying, I remember at the start of the pandemic when we saw such stark racial disparities here in the state, a whole lot of us got together to try and figure out how can we address this. And many of you in this room were part of those conversations. And I remember one in which we were talking with the CDC and about the fact that we just didn't have good data on who was being impacted, and that often healthcare providers felt uncomfortable getting that information from people, and it's optional. A community health worker, actually, Lita was one of the people who spoke earlier, and also another person who has a lot of community health workers at our organization, both said, we have community health workers who ask these questions all the time with the most vulnerable populations in our state, and they get those answers. So there is a way to train providers to ask those questions. If we can ask people who are actually at risk because of who they are, like we should be able to get providers to ask people who aren't about who they are. And I thought that was like that has stuck with me all these years. And I think it really made a difference in the advocacy of the CDC around, like, you have to take more proactive steps to try to do a better job of collecting this data. And I also just wanted to know, I think Speaker Talbot Ross had to leave, but she's led the effort of passing 2 bills at the legislature that are looking at how we collect data around demographics across all of state government. And that's a good example of why it matters that we have people like her, like Representative Block in the legislature who say, I understand how my community is being impacted by things that you're not even looking at. And so we need to change our whole system in order to make sure we're looking at people who look like me and other marginalized communities. So just emphasizing the importance of that. We need real systems change to make that happen. Kate, what do you think about the CDC?
Can I have a chance at the data question?
Oh yeah, I can ask both of you.
Okay, data question.
Okay, yes. Kate, and then Becca.
I thought we were.
No, I'm sorry. I was interrupted. I'm sorry.
Data question. Okay, I got it. So like Kathy said, Maine CDC, specific to the oral health program, has been lacking data collection for many, many years, and that's been something that we've been looking at extensively at how that can be improved upon, but that's also capacity dependent. And at the state oral health program, I've been the only person in the program for about a year and a half, but we do now have a oral health educator, Ryan, that we're really excited to have on board, who will also be able to utilize as we collect data. What do we do with that? Like, how do we make the most out of that data? It takes a lot to get a lot of good data. And you don't want that effort to go unnoticed. And we finally have a chance between Ryan and now an EPI that will have access to at Maine CDC for oral health, a chance to really start to think about these things on a deeper level. Across the state, we've really been focused on children's oral health, where we should be across the lifespan. However, as all of you know, funding and resources and capacity affect all of those decisions, but that doesn't mean that we still can't think about ways to improve them. And with that, I'll pass it to Heather.
Thank you. Yeah, I was excited to talk about the data question. So I thought I was going to miss my chance.
I can't imagine talking about data and not asking Becca.
I am a little bit of a data nerd, but actually one of the first things we did at COME when COME was created was to look at the all-payer claims database, which is a source of data that we're very lucky to have in Maine. It's not available or not as robust in every state, but it includes the claims from both commercial and Medicaid insurance, and we were the first ones to do an analysis of the dental claims in the all-payer claims data set, working with our partners at Muskie, and so we've now done that analysis since 2018, like looking every year, like what is happening, at least for kids who have insurance coverage, public or private, what care are they actually getting? And it's been hugely illuminating for us to be able to see actually how bad access to care truly is, even for kids with insurance. And so we know there are about 200,000 kids under age 21 in Maine who have regular, consistent insurance. There's another 100,000 kids who have either inconsistent or no dental coverage at all. And so being able to do that analysis has really shown us the scale of the challenge that we're at, and has helped us to understand that the traditional dental model of going to an office every 6 months, even though we knew anecdotally that that doesn't work for everyone, we know that we're nowhere close to meeting the scale of the need. Because of those 200,000 kids with insurance, even before COVID, only about 77,000 had an active dental home. So that's an example of sort of coverage not equaling access. For kids with Maine care, it's about 20%. And we haven't recovered since COVID yet, even to pre-COVID levels. So it's clear that has been really helpful to be able to use that data to make the case that we have to do something different. We have no choice. We have to build out a system that has more delivery models available than just the traditional four walls of the dental office. And so that has sort of freed up, I feel like, our ability to collectively dream of a future dental system in which care can be accessed, at the right place, at the right time, the right care, okay, I said that in the wrong order, the right care at the right place at the right time, for everyone, and getting kids prevention early and often, and early intervention if the disease is starting, is essential to also being able to make room for adults in the system. We have to be able to do both. And so, as I came into this work, it always felt really strange to me that it felt like there were some people who had access to care their entire lives and couldn't see what it was like not to, and then there are other people who have never had access to care and can't necessarily see what it's like to have it, and that the data is what helps us bridge those worlds along with the stories, that we've got to understand all of these multiple experiences in order to envision a system in which everyone can access care in the right way for them.
Thank you so much for that. So we're going to talk a little bit about partnerships and their importance. And I mentioned earlier that when we were working to advance the adult dental benefit, it was really a coalition of partners from many different backgrounds. I just wanted to speak a little bit from this perspective too, that part of that we believe strongly is also including people who are directly impacted by the policies in not just coming and sharing their stories, part of the process, but in actually helping decide what is the policy that we need to, for the solutions that we need, and also have real decision-making power around that within the advocacy process, which is a really different way of doing advocacy than how we normally do it at the State House or really anywhere. And I just wanted to name that we had a leadership team of directly impacted people, which required resources to help support their engagement in that work. And to whether that's helping with child care, whether that's providing a stipend or some other sort of compensation for their time, whether that's helping with some of the background information about the process of the policy process, and also about the types of policies that are available to us. All of that is an investment, and a lot of funders don't look at that as an investment. So when we think about funding and how that plays a role, I think funders, like those in the room today, are important in helping us be able to really include those directly impacted people. And I also think it requires legislators who want to hear from them. Like Speaker Talbot Ross, for example, has been the leader on our All Means All campaign to remove exclusions in the Maine Care program. And we have a leadership team that's led by folks at New Mainers Public Health Initiative, which is in the room representing Maine. And when we say decision-making, when there was a moment in our campaign where we thought maybe we could make progress, but we're not going to get our whole bill, but maybe we need to make a compromise, we had already had some conversations about compromises with that leadership team, and we knew we were unwilling to compromise along any immigration status lines. But we were trying to figure out, should we compromise and try to advance coverage for parents or for older immigrants? What does that look like? Speaker Talbot Ross understood that we actually had to go back and talk to our leadership team before we could make a decision about the amended bill that we might put forward. And that takes time, and that's a process, and it requires trust. And we're not there on all the issues that we work on. I don't want to pretend that we have this figured out perfectly, but I think if all of us start to think more and more about how do we actually have leadership from and decision-making power from the people who are lacking access to care, we will create better systems together. So with that in mind, Becca, do you want to talk a little bit more about the partnerships for COME?
Yeah, sure. So COME, there are only two of us who are staff. Haley, raise your hand, and Haley Hess is our associate director, and myself. And so everything that COME does is done by the partners in the network. Our role is not to run programs. Our role is really to provide the support, the glue, the convening, the coordination, the resources. We do a lot of grant writing and bring in grants, and most of the funding goes back out the door to partners doing the work. So that is really, it's the backbone support for the network is what we do. And so the solutions all come out of partnerships and collaborative work groups, projects, grant opportunities. Whoever sees, a solution that requires collaboration and multiple partners coming together can just get it started. And we have to try to bring resources and capacity supports to it, whether it's data or, advocacy organizing or funding or whatever is needed to try to help that work get off the ground and get traction. And to help providers who are interested in testing innovative models, delivering community-based care, supporting pilots of those models, and then supporting evaluation and sharing the results so that other providers can learn from it. So it's the whole thing is partnerships. That's all it is, really.
Thank you. Courtney?
So the role of Maine Care is interesting because obviously we're a Medicaid agency and we are a payer for services. And we are part of state government. Maine Care is unique because there are only 5 states in the country, including us, that do not have managed care. What that means is we as a state are providing Medicaid services, where in other states we pay a managed care organization a health insurance to then provide the service. So we have a little bit of a unique opportunity and what I think of personally as an obligation to care and provide care and access for Mainers to have access to health care. I also think that healthcare is a human right, and Maine Care only covers a certain subset of our population, and we all know that there is a gap. There is a gap between employer-based insurance and the exchange and those that are just over income for Maine Care, and those, as we've articulated, that are non-citizens that don't have access to Maine Care at all. And so I just wanted to name some of these particular gaps in coverage in particular in thinking about partnerships. Maine Care, again, is part of the pie and not the whole. And so how do we make sure as we are extending Maine Care to the fullest extent possible to provide access to health insurance while also realizing, okay, how do we provide care and access for everyone that's not covered in Maine Care? So that feels really important. I wanted to highlight a few programs in particular to demonstrate kind of the unique role of Medicaid. So part of my role is to apply for an 1115 reentry waiver. And this is really unique. For people who are incarcerated, it's a federal statute that you can't use Medicaid to cover services for those individuals. And we all know that this is a marginalized population that comes out of a jail or prison and faces large barriers to accessing care and really poor health outcomes, high rates of overdose death. So I'm helping to lead an effort where we can apply to the federal government for an exemption where we can use Maine Care, turn Maine Care on for those individuals 90 days pre-release. That will completely change the landscape for individuals who are incarcerated to receive case management, care coordination, improve the floor of the care provided around NAT, around dental access, around doing planning so we can address some of those barriers before someone's released. That work is essential, and one of the things that we keep coming back to in this day is really thinking about how do we work with people that are directly impacted. And so one of the things we've done at Maine Care is we have partnered with the Maine Prisoner Advocacy Network. Maine Prisoner Advocacy Network are people that have been directly impacted by the justice system, either themselves, loved ones, and we are partnering with them to hold listening sessions in jails and prisons so they can directly inform our policy. This has been essential for me to say, hold up, to do things equitably, we have to slow down and be intentional. And it has taken forever, you can imagine state government, to partner with a small nonprofit who will then pay people who are incarcerated so we can not be extracted and not ask for their stories and not to compensate them. We are compensating them for their time and their lived expertise. And that's something that we've talked about now that's come up a number of times. We can't continue to ask for free labor and for people's stories and to be extractive. Maine Prisoner Advocacy Network hold those listening sessions without Maine Care, without DHHS in the room. So they can have open and honest conversations about what the barriers are, and what they need from these programs. So that's what partnership can look like when it's intentional. I'm not saying it's perfect. No process is perfect, but it has to be slowed down for us to actually create lanes for equity. And you can imagine it was not easy to get to that place. We had to, a lot of people were like, well, we've never done it that way. We can't pay that. We can't come up with these contracts. And we said, well, we can and we will, and we'll figure it out. And we did, and we feel really good about that. But that's just one program and one partnership. And so the hope is that as we develop policies within Maine Care, within state government, that this is what we're actually doing, that we're taking it from the state level and bringing it to the ground to say, from you all, as experts, how can we do this better? How can we design a program that's actually going to meet people's needs and not just be a state decided for folks?
Thank you. Kate?
Questions?
Yes, so I think all of this work is catalyzed by partnerships and leading into what each other is already doing for work. And a good example of that would be the Cumberland County project, where there's multiple levels of organizations, whether it's a clinician, we have a math professor who's involved. It's a partnership between Greater Portland Health, Children's Oral Health Network, Mainly the School Oral Health Program. And this is to try to provide infrastructure. And Liz, wherever she is, there she is, with the Cumberland County Public Health District work. This has allowed us to really work together on a public health district level, look at the resources that we all have together, and how do you catalyze those resources? Where are those gaps? And that's just one example of thinking about access to care for oral health, but another piece of that is the workforce. And you'll hear me talk about the workforce a lot, but one of the collaborative efforts that we're doing is the Oral Health Navigator training, or the Oral Health Navigator role, where we are adding an oral health skill set to your toolbox. And you don't have to be a dentist, you don't have to be a doctor. This is on the ground style training where it brings accessibility to other roles in oral health care or dentistry or whatever you want to call it, public health dentistry. And it allows other folks to dip their toes into a workforce that they may not have ever had the opportunity to do so because of the cost of education, because of disadvantages, because of inequities. And we need these folks in our workforce. And that's all of us in this room. It shouldn't matter the color of your skin, your race, anything like that. Everybody has something to bring to the table, and they should. And we should be able to catalyze that and really embrace that.
Thank you for that. And I realized I sometimes just skip like the most important question. I feel like, but it's a good way, I think, to come close to the end. So, from your perspectives, what would it look like if everyone could access oral health care in the way that they need, that feels safe and accessible? And are there one or two tangible steps that we can take now to move closer to that? And Keith, I don't want to start with you this session.
So I'll just be clear, this is more of my personal opinion, not the CDC's opinion for this specific part of the question. It's really hard for me to imagine what access to everybody would look like because I've never experienced it myself. And probably the majority of the people in the room here. That being said, there's a lot of work that needs to be done for a type of vision that I feel as though I would have for what that means to have access across the board for all people. But that would include affordability of care, culturally competent and trauma-informed care, reduction of geographical barriers. No, we cannot pick a mountain up and move them, but I'm pretty sure we can figure out innovative ways to get around them. And utilizing those innovative strategies, including making public health education and oral health more widely available, both in regards to actual health itself and workforce advocacy advocacy, how you can get involved. So there's many different layers that I think need to exist for a world like that.
Thank you.
Also, without my state hat on, I would say I would love a single payer system. That way everyone has access to health care, period. And I think the other piece that feels really important to me is to destigmatize Medicaid, to destigmatize Medicare. We have providers that don't want to sign up to be Medicare providers because they think there'll be more no-shows because the members are more challenging to serve, and those things drive me absolutely bonkers. We have to flip it, and we have to say everyone deserves the right to high-quality oral health care. And so addressing the stigma in Medicare feels really important.
Yeah, I do feel like I sort of wove some of this into my previous answers, but I think even before COLE was started, there were a lot of community conversations happening, asking people, sort of this question, like what do you need? What kind of care do communities need? And we heard over and over again, like, we want prevention. We want to stop the disease before it starts. And we need that prevention to be out in our communities. Why isn't it part of our health care? Why isn't my doctor or my primary care provider talking to me about oral health? Why can't I get fluoride varnish right in the primary care, right in the well child visits? Why do we have to go to a separate appointment? Why can't the kids get it in schools? If they can get vaccinations in schools, they can get vision screening, hearing screening. Why can't we do the oral health screenings in schools? So I think a lot of the movement for community-based care comes out of sort of all of those really common sense, community-driven ideas about what works for communities. And so that is sort of where most or all of CONE's effort is going, is in really pushing care out into communities, broadening and diversifying the workforce, and making sure that there is sustainable financing behind the system to deliver that kind of care that communities really want. And I will maybe just put a plug in quickly for some things that we put out on the tables. If you are sort of interested in more specifics about what some of the different work groups and projects and initiatives are working on, there's kind of a smattering of things out on the table. And I would say that if you, there's a QR code on one of those things that is to sign up for the CONE e-news, and that is really the best way to sort of hear more on an ongoing basis of like what some of the projects are, what some of the initiatives are, ways to get involved. So I would definitely encourage you to do that if you're not already subscribed. There's also, if you're someone who's a caregiver or a parent of young children yourself, or you work with parents of young children, there's a larger QR code on one of the half sheets of paper that's to the Dental Steps Library, which is a pretty new series of videos created by by the Health Integration Action Team within the network, and those videos are like 2 to 3 minute videos. Regina stars in one of them, that are lined up with the age of well child visits. So like you can get just a 2-minute nugget of really solid scientific oral health information to help protect children's oral health, lined up with each age. So we put those up, those might be useful too. There's also, we're starting an effort around collecting some of the stories, because there are so many stories out there of people sort of banging their heads against the walls of the system. And we need those stories to get heard by policymakers, because it's one thing for us to pass along, kind of like this is a problem, but if we're passing it along third hand, it doesn't have the same impact as when community voices are really being raised directly. And so that effort is to try to create more avenues for policymakers and people in power to hear directly how this is impacting our communities. But we are also happy to hear stories of solutions, and where you see something working. Even though that particular flyer was geared towards the frustrations, we do really want the joy as well when we see something working. And there are lots of ways to get involved in advocacy efforts. And so if you're interested in advocacy, whether it's personal advocacy with your own providers, or in your community for your school to sign up for the school oral health program, or you're local pediatrician to participate in From the First Tooth, or your community water system to stay fluoridated or get fluoridated. There's so many different ways to get involved in advocacy, and so Kaylee is really the leader of our all things advocacy. So make sure you connect with her today if that's something that you're interested in. And really, we just want to hear what other ideas people have. Like, if you see a solution, we want to hear about it, so that we can help connect you to other people that are interested in those same kinds of solutions and get some traction going.
Thank you so much. And we're going to run out of time in just a minute and a half. But just before we go, are there any? This is like such a big puzzle, and are there any last thoughts you have to help us continue to feel engaged in such a big task? I know it's a lot to ask in a minute and a half, but does anyone have any kind of thoughts?
A few. We do have the dental submap committee that really helps. It is an advisory committee that informs Maine Care, like is something that, all of us are on that, and that is a wonderful way to bridge with the experience happening on the ground to Maine Care, so we can continue to address system level barriers. So dental submap is one way to get engaged. So communication came up as a huge issue. So much is happening in Maine Care, and many people aren't aware. Sign up for our e-alerts or e-newsletters so you can hear when it's time for public comment, when policies are opening to be changed. So please engage with us that way. And again, public comment. Really appreciate your input on it as well.
And if you're looking for the sections of rule that apply to oral health care and Maine Care, it's section 25. So that's the number to look for. Kate?
Yes, I think there's many different ways you can get involved, and I'll speak specific to the school oral health program, where we are trying to expand into all schools, all grades. And you can get involved if you're a parent, caregiver, or even if you don't have a child but you live in that district. And one of the biggest barriers that we're seeing is school systems not understanding the importance of oral health programming in their schools. So advocating for oral health services, the importance of learning about oral health in the school setting, are a couple different ways, parent-teacher organizations, superintendent, things like that.
That's great, thank you. That's all.
I feel like I kind of answered that.
Okay.
So free up time for other people.
Thank you all, and we would, as Becca said, love to hear from all of you. So if you have thoughts about what's missing from what has been shared this morning, or other solutions that maybe we haven't even thought of, please do reach out to all of us, and we'll be here for the rest of today.
I want to make one more random plug that I didn't think about for a second. Is state government thinking about changing systems? We really need people who have on-the-ground experience to come and be involved in state government. Look for jobs. Come work with me on this. Look at DHHS. We need people that understand what it's like to navigate these systems to be able to actually change them. We have many people that have been in roles for a long time that have never provided services. They have no idea what it's like to navigate these services. So please consider working for state government, joining us in this effort.
Hello. Thank you so much. What an amazing panel. Truly, thank you very much. Really appreciate all of the information. It's so helpful to get everybody in the room and listen to what's happening in the state and what we can do, obviously, to solve this huge issue. We're going to lunch. So you have an hour for lunch. So feel free to grab some lunch. Talk to folks and that kind of thing, and we'll be back at, I have no idea what time it is, I keep saying that, we'll be back in an hour.
those things.
I think oral health equity looks like a lot of different things. The biggest piece to me is who can afford to go to the dentist? Maine Care just recently decided that they're going to cover oral health care, but equity to me would mean all Maine Care patients know that that exists. So most of them don't even know that oral health care is covered. Equity means that there are actually dental providers that take Maine Care. Can I get to my appointment? Do I know who to go to for the right kind of appointment? Can I afford my appointment? And do they speak my language at my appointment? Those are the biggest things to me.
There's a lot of information that we're going to be hearing out in this conference, not only about taking care of your teeth and taking care of your mouth, not only looking at healthcare and the effects of oral health on your overall care, but it's also looking at some policies, because we can't change systems unless we also look at policies.
I think the next step for CCCS is to look more funding. There are so many Mainers that don't really have access to oral health. There are white communities who are poor, who live in the rural areas that may not have any dentists there. So how can we really make sure those communities have oral health care? We're really working throughout, but we need more funding in order for us to really reach those communities that do not have the care that they need.
So as we get into talking about oral health and how it intersects with race, we wanted to give you some statistical information. Oral health, so among adults, only 47% of multiracial Mainers and 39% of Indigenous Mainers saw a dentist in the past year. That is compared to 66.2% of white Mainers. How many of you knew this statistics? A couple of people. And so that's why this topic is so important to us, and that's why it's so important that we are here today when we take a look at oral health and how it intersects with race. And we heard this morning from our presenters that oral health isn't just about oral health, right? Kathy Kilrain Del Rio said it best. It's about your overall health, and that's the message that we have to give out, not only to communities of color, but all of our communities, because sometimes we don't see the connection. And so with the economic downturn due to the COVID-19 pandemic, it was especially harmful for BIPOC communities. I don't think we have to go back and tell you what happened during COVID. Hopefully, you guys have heard about what happened with communities of color, especially the Black community in COVID. The temporary closure of dental offices, and in some cases permanent closures, and school-based programs played a role in further increasing barriers to care. They didn't have a choice, right? There wasn't a choice. If people aren't coming out of their home, if people aren't going to the dentist, right, then most offices had to close because they did not get the patients that, they didn't get the patients because everybody was staying at home. And so that just compounded everything. Oh, sorry, I keep forgetting to tell you next slide. It's a good thing she knows me well. So just want to give you a little bit of information on the Oral Health Equity Collaborative. In 2022, CCCS established the OHEC, we call it OHEC, Oral Health Equity Collaborative, to include BIPOC-led and BIPOC-serving organizations, oral health providers, and the UNE Dental School, focused on addressing, and the state CDC with Kate Christensen. School focused on addressing and improving oral health access and outcomes, system change, and I can't talk today. Disparities for BIPOC in Greater Portland. And with that, CCS was granted a 2-year grant from the Office of Population Health Equity. And within our grant, because we did not want finance or funding to be an issue, we looked at some organizations within our OHEC and said, how can we make sure that you continue to be around the table and have this conversation? And so we asked, do you need money in order to participate? And they said yes. So what we did was we partnered with 5 organizations within OHEC, and they now get some of the funding that we got in order to continue this work. There were others in that OHEC partnership that said, you know what, we're good, we're covered, we still want to be involved, but we don't need any financial assistance. And I will tell you that the whole reason why we started the Oral Health Equity Collaborative was because of Becca Minou Jones and Kaylee House. We started having conversations with them because, like Minou said, when COVID was around, a lot of us didn't brush, we didn't go anywhere. So even though a lot of us didn't brush our teeth every single day, right? And so the conversation was just, how do we get toothbrushes and toothpaste into the hands of people of color? Then as we started going down this road, as we continued to talk to Becca and Kaylee, we're like, whoa, and it opened up a whole new world for us, a whole new world. And now we have the Oral Health Equity Collaborative. And these are the folks that are our partners. And so if you can stand, if you're a partner, I just want to acknowledge your work, your continued work with us. And again, just recognize the fact that we're in this together, community and providers and the state, and it is working. So we have the Children's Oral Health Network. I see Kaylee here. I think Becca might have to leave early. Oh no, she's back there. So if you guys can stand, we have the Children's Oral Health Network, Maine Teeth, the Cumberland County Public Health Council of Public Health, the Maine CDC, the University of New England, I see Dr. Minou back there, Greater Portland Health, the City of Portland, and Maine. Did we leave anybody out? I don't think we did. We left out community dental.
Thanks, Regina, thanks.
How could we leave out community dental? I'm so sorry.
We're not very inclusive of this.
I know.
And we're so inclusive, right?
I know. I'm so sorry. That's right. It's in that. That's right. That's right. Well, I apologize for that. Believe you me, this every time we get together, every time we all get together, we have a quarterly stakeholder group, and every time we get together, I am amazed at all of the work all of these partners are doing. And I'm also amazed that they continue to show up at our table. We talked this morning about, communities of color not being invited to the table. This is our table. This is cross-cultural table. And we have community providers that are showing up to our table saying, we get it, we understand, we want to hear from you. What can we do to help you? So that's why this collaboration is so vitally important to us and why we feel we have to keep it going. So that's our OHEC team. And again, if you're sitting there thinking, I have something to share, I want to get involved, we certainly welcome your involvement. And so what does OHEC do? We have mutual support and learning to strengthen the capacity of oral health centers and serve BIPOC community members, effectively increasing access to culturally, I'm going to say it again, increasing access to culturally responsive, high-quality care. It has to be culturally responsive. Because again, we heard this morning about a lot of communities that don't trust, and that's why they're not going to their oral health facilities. They're not going to see a dentist. We talked this morning about some folks who come into this country and their teeth are so badly decayed, and with the trust, it just compounds that, and it just continues. And so it's really important that we make sure that we have access to culturally responsive care. Members engage collaboratively to find ways to dismantle systemic racism within the oral health profession. And believe you me, somebody mentioned it this morning, trying to move a mountain is really difficult. And so we've had about 2.5 years with the Oral Health Equity Collaborative, and we continue to see gains and strides in there, but we're nowhere where we need to be. So the goals of OHEC is to grow the capacity of providers who take Maine care and have sliding scale speeds. Again, this is why you don't give up coffee. I'm going to step through here again. To take Maine care and have a sliding fee scale to serve more families. And Becca and Liz Bucklemore, they work on this every single day. And also our folks at the CDC and at Maine care. We need to find more dentists that take Maine care. Because we're working out there with the communities of color, and we're saying to them, hey, look, you now can get Maine care, and Maine care will cover your dental care, your dental needs. But if there are no dentists out there that take Maine care, then we're just spinning in a spiral there. And we're not allowing folks to have access. So that's goal 1. Goal 2, to strengthen providers' capacity to give culturally responsive care. And to do this, CCCS has been training oral health providers using our uniquely designed and tested oral health and race training. We did it specifically for Maine teeth, community dental, and Greater Portland Health. And they came to us and said, hey, you do a 5-part training series, we need it. We have questions, right? Because this partnership is between communities of color, nonprofit organizations, and providers. So if we're not talking to providers and we're not providing practitioners and providers that information, then we're doing just the same amount of harm. So it's a partnership. It's a partnership. And that partnership has to include everybody. And so we did some training to community dental and Greater Portland Health and Maine teeth. And we'll continue to do that, right? It's not like we can say, you can take our 5-part training series and then you're done. Right? That's just the tip of the iceberg. And so we will continue to look at that as we continue to have OHEC and grow up OHEC. The second one is we need to strengthen capacity of community-based organizations to help their communities access care and achieve oral health and develop relationships with provider organizations to continually improve how the providers do their work. Again, it's a partnership, right? So we have to say to our communities, we have to say to them, hey, look, we're just talking about Maine folks. You have to say to them, hey, we have a good relationship with Greater Portland Health. We have a great relationship with community dental. We know that they care. We know that they want you to come to their doors. We know that they're willing to work with you. We know they're willing to hear what possibly you didn't like or your successes. We know they want to hear from you. We can be that liaison between the community and our partners, especially the ones that are providing oral health care. And so we've been trying to bridge that work as well. And we're not the only ones doing this work, right? The City of Portland Health Equity Program, they started this work. We're coming into it. They started this work. The leader talked this morning about the alignment that they had, right? And so, I'll give you that old cliche. It takes a village, right? It takes an environment. It takes a whole society in order for us to kind of make this change. Oh my God, I didn't say next slide again. So to understand how to best improve relationships, access to, and quality of oral health care, CCCS has gathered data from oral health providers and marginalized community members through surveys and focus groups in the summer of 2024. So remember at the beginning of this, I said we kind of did it wrong. So what we did was we worked with Children's Oral Health Network. It wasn't that we did it wrong. We said to them, what are the main issues? And they said, here are the main issues. We said, okay, this is what we're going to tackle, right? And then we realized, after doing this work, we realized we didn't talk to the community to find out what their needs were. Like, did their needs match up with what Children's Oral Health Network had told us and what we had experienced in our own community? So we said, you know what, let's go talk to folks. Let's go talk to the community and find out from them what they're seeing as far as their oral health and what they need. But again, because it's a partnership for providers, we also needed to talk to our providers. We also needed to say to them, if we want culturally responsive care, how do you want us to get there? So as a provider, what do you need for us to do in order to support you? So we did surveys and we also did focus groups because we wanted to get as much information as we possibly can. And the issue with that is because we're a Greater Portland organization, we didn't do it statewide, but we're Greater Portland, but it starts to give us the data that we need. We talked about data this morning, right? And so we know what we know, but we still need the data in order to go say to folks, here's the actual data, it's not us just saying this. So we went out, we did surveys, we did focus groups, we collaborated with a research organization. We asked community members that identified as BIPOC and or LGBT to complete the survey, and we got 557 responses. We had a total of 7 responses for providers. Now, it wasn't the number that we got at, but you're providing the care. Right? And so, and not only that, but from the information that we received from being part of the Oral Health Equity Collaborative, we did have some of that information. So all information is really helpful. So we're grateful that we were able to at least get some from providers. So we had all this information from the community, all this information from providers, and we were looking to see if our oral health equity strategic plan, if we were right on track with that. Did it need to be changed? Were communities saying the same exact things that we knew? So it was really important for us to do that work with the community and providers. And so we conducted the focus groups with 5 marginalized communities. Each group had 10 participants. We had Somali and Arabic speaking, the LGBTQ+, American Word Black, the Khmer community, French and Portuguese speaking, African immigrants. So we couldn't do a focus group with everybody, and these were the communities that we decided we were to do the focus groups with. We tried to do focus groups with the Latinx community, and unfortunately, things happened and we weren't able to do it. But we continue to reach out to folks in the Latinx community in order for us to get that data. And when we get that data, it will be added to our report. So I'm just going to go through some key findings that we got. So CCS partnered with Market Design Research to get the report with findings and recommendations based on our surveys and focus groups with community members and oral health providers. Over 54% of respondents have dental insurance. That's pretty good. That's half. I mean, it's not great, but it's better than lower than 54. 24% did not have dental insurance, and 22% have no care. So that's something that we want to look at, right? We need to look at why only 22% have Maine care. We want to bump up that number. We want to work with Maine care. We want to let folks know that they may be eligible. We need to help, again, increase that number. And 39% of those with Maine care believe they were treated differently because they have Maine care. You guys surprised? Right? And so when somebody, I can't remember who talked about it, who was it that talked about the stigma? Was it Kathy, was it you? It was Courtney, thank you. There is a stigma out there. We were talking a little bit about it with the Maine care folks. We need to lower that stigma, that having Maine care doesn't necessarily mean you're poor, it doesn't necessarily mean you're dirty, it doesn't mean that at all. It just means that you need some financial assistance in order to access oral health care. There's nothing wrong with that. And so that's another thing that we need to take a look at when we talk about oral health care and health care in general. So these are some of the key findings, right, that we got. As far as respect, folks said they felt discriminated due to marginalized identity. Again, not a surprise there. Trust through personal interaction. Desire for more BIPOC and LGBTQ providers. Everything we talked about today. Right? Everything we talked about today. Trying to figure out solutions. Difficulty navigating the system, the language barriers. We've been hearing about the language barriers for a long time now. And I do think there are folks, and there's folks in the community, and I do think there are folks in our oral health systems that are really looking at language access. I know that, who was it? Maine Access Immigrant Network just did a bunch of interpreting for Maine Teeth. Because Maine Teeth was like, hey, we need some help. And Maine was like, you're here. And they did it with help from funding that we gave them. And so, and then the long waiting periods. Right? Again, it gets back to the fact that we just don't have a lot of dentists for a lot of reasons. And we need help understanding our oral health system, insurance and treatment. And so it's confusing. Our systems are so confusing. You go down the road and you ask a question and you get 20,000, other answers or other questions, and then somebody's telling you, oh no, you're on A Street? No. You're supposed to be on B Street. And then you talk to somebody else and they go, you're on B Street? How'd you get to B Street? You go, well, A Street told me to come to B Street. They go, no, you're supposed to be on C Street. These systems are all interrelated and they're all so confusing that even somebody who was born in the United States can't maneuver it. It's just too complicated. And so we need to take a look at that. Access, of course, is cost. Even if you have insurance, some folks still can't afford to go to the dentist. It's just too expensive. Transportation, we mentioned that today. Transportation is a big, huge piece of it. When we talk about folks out in rural Maine that have to, take a 2-hour drive in order to get access to healthcare or healthcare. And most providers that accept Maine care, you need to know who accepts Maine care, and again, work on those who don't. And then as far as mental health, the mistrust and the helplessness. So you have a mental health, you have an oral health, you're Black, you don't speak the language, you have a perfect storm. It's an absolute perfect storm for somebody to say, I'm out. I can't maneuver this system. I have too many things, whatever, I just can't do it. Especially because of the mental health. That's another thing that compounds this. Another thing it makes more difficult for people to access not just oral health care, healthcare in general. And if you're not accessing healthcare in general and you're not accessing oral health care, that's where we're getting to a place where we're at as far as the differences in healthcare between communities of color and white people. And then their fear, anxiety of pain, lack of cultural understanding. And again, we keep talking about that partnership. And both folks have a role to play in that. I think it's really important for communities of color and those folks, like Dr. Vera and I, to go out to folks and say to them, we know the folks that are doing this work. We work closely with Melissa. We work closely with Jen. We work closely with the state and Maine and the CDC and Maine Care. We work with these folks, so it's okay. You can trust the folks that are providing you care. And if you can't, we'll help you figure that out. And not only that, but if you had a bad experience, they want to know. Right? They want to know. Because they're all about working together and they're all about working in this partnership. And so, that's the way it works. Not everything can go perfectly. And so there are those times where folks truly feel like they've gotten really bad service because of color this time. Right? It's the same old playbook. It's not a new one. But again, it's up to us to say to somebody, wait a minute. We have relationships with a lot of folks, and we're going to make this right for you. And dental emergencies causing trauma. Right? So somebody already has that trauma. They have that mental health. And then they go to somebody, they go to the dentist, and then they're traumatized again. So then they're left with, do I go back? I have 75% of these already traumatized. And that includes my trip to the dentist. 25% of me is you're going to convince me to go back? And then tell your children they need to go? So these are some of the key findings, and I'm sure many of you are saying the same, yeah, Virginia, we knew that. All right, we knew all of this, so we knew some of it, right? But the thing for us is now we actually have the data to be able to go to folks and say, here it is. We've talked to people, we've talked to a lot of people, we've talked to our partners, and here's the data. So we then broke it down, so we got our overalls. Then we broke it down to the provider key findings. And so one is the environment. Half of the respondents in their practices efforts, creating a welcome environment for all patients. So often we say to folks, or I say to folks, when I walk into a new place, right, as a person of color, when I walk into a new place, I want a poster that looks like me. I want a magazine that has my people in it. Right? I want somebody sitting across from me who's taking my name. I want them to look like me. I want to see somebody when I go back into the office to see a dentist. I want somebody that looks like me. And so, taking a look at your environment and your facility, and just really kind of looking at it from a lens of somebody who doesn't look like like you? What would you want to see? What would you want to see? That's what I want to see. And let me tell you, if I don't see it, I'm calling the two of them over there and going, oh my God. I was just at such and such a place, and let me tell you, there was nobody there that looked like me. Right? Because there's a good possibility we won't go back. Right? We're always saying, what is that saying? That's really bad for somebody to be in my head. What is it? It's first impressions. First impressions, right? First impressions is everything. Right? First impressions is everything. So if you go someplace and you're not getting what you need from that first impression, if you're not seeing folks that look like you, if you're not seeing posters that look like you, or magazines, right? You're gonna go, I don't know, I don't think they see me. Well, I don't know if it's a good idea for me to come back. The other thing is cultural responsiveness. Only 50% of providers surveyed have undergone formal training on working with BIPOC, immigrant, LGBTQ communities, and LGBTQ plus communities, right? We need to know our history. We need to know how to work with folks, because again, that's how that's going to decrease that feeling of mistrust. So we used to work with somebody who actually worked at Grand Department of Health. Wonderful person. And she would be able to say hello in like 9 different languages. So when anybody came into her office, she would be able to say hello. Not only that, but she had pictures and that kind of thing, of just all kinds of different things. So that somebody felt welcomed. And so, believe you me, I tried to learn Arabic. It was just to say hello.
Can you try?
No. And needless to say, I got kicked out of class. And the BA told me she'd never ever teach me how to say anything. So it can be difficult, right? Health equity. 35% of providers expressed their desire to attend oral health equity training, and 24% are interested in helping their communities gain easier access to oral health care services. Very difficult, right? This is very difficult. 35% of providers expressed their desire to attend oral health equity training. When? You're seeing patients from 8 a.m. to 5 a.m., right? And so it does take a different mindset on, what the priorities are and trying to be educated and trying to be knowledgeable. And the other thing is nobody said this was going to be easy. This is all hard. This is all hard for us. It's not going to be easy. And so we're asking you at some point in time to kind of step out of that comfort zone and go, we understand that our priority is for us to provide oral health care for our patients, but in order for us to provide care so that somebody will continue to come back and so we can build that relationship, is for us to go ahead and do some training and learn more about the communities that are here. Nobody's saying you have to learn everything. It's too overwhelming. You certainly don't have to learn anything. But there is some information that you can learn. Providers express the most interest in training around racial definitions, cultural responsiveness, and understanding the process of resettlement and transition to the United States. Those are the things. And so, from doing all of this, what are the recommendations? Right? Increase focus on health equity initiatives, address discrimination, specifically within the LGBTQ plus community, expand patient advocacy and financial support, enhance patient education, because if we can enhance patient education, then they'll go, I think I do need to go to the dentist. Encourage active participation in diversity initiatives, strengthen efforts to create welcoming environments, culturally sensitive care, improve language access, simplify Maine care navigation, improve emergency care access. Those were some of the recommendations that we got. And those are the main recommendations. Here are a bunch of others, and I'm not going to read it to you, but I'll give you a couple minutes to read what some of them are here. You can't see it?
Can't see it. It's just because the screen is the screen. Yeah.
Oh, all right. I take that back. Let me rewind. Let me read you. Emphasize preventive education. Foster foster personal interactions. I know when you go to the doctor, they sit there and they have all the questions that need to be asked. Instead of looking at looking at the phone, whatever, just ask them to tell you what's your story. Just tell me your story. You'll be able to get some of the answers to your questions. Provide paperwork assistance. Expand financial support and low-income services. Strengthen provider-patient connections. Attract and retain BIPOC providers. We talked about the navigator training. That's a start. Offer tailored care. Focus on empathy and active listening and training. Increase representation and outreach in BIPOC communities. Because the other thing is that for anybody in the system, for anybody in the oral health system or the healthcare system, you can't sit back in your office and wait for the community to come to you. And we can only do so much to get them to come to you. And so it's really important for you to actually go into the community. And that's, again, how you can build some trust. Address concerns around Maine care treatment. Reduce wait times for appointments. Enhance satisfaction and quality of care. Ensure pain management and clear communication. Remove unnecessary barriers. Ensure transparent communication. Provide clear information on insurance. Reduce racial bias through training. Not easy, but again, this is what we've learned. And so, in addition to our recommendations, we did create the posters. You will see all the posters over there. We want you to take, a poster and put it up in your office. We want everybody to have this information. And it looks like we have plenty of them out there to share. Done. So at this point, what questions do you still have? Or what are you doing in your communities? We want to hear from you. Oh, yes.
So I'm just a little frustrated because I'm so tired of going to conferences where all the other communities but the Hispanic community is involved. So as a community health worker, what can I do for our voices to be included? Because almost every single one of my families, the need for dental care is so intense. Like, they'll call me and they'll say either I need legal representation or I need to take my children to a dentist, and then I feel bad saying okay, I can put you on a wait list with community dental and it'll take forever, or I can refer you to UNE's dental thing too and it'll also take forever. Or I personally have to go above and beyond of my job expectations and transport people to Bridgeton or other places where there is dental care. So what can we do to ensure that our voices are also heard? Because like I say, I went to a conference once and all they talked about was everyone, all the new Mainers, everyone but the Hispanic community, and I'm so tired of there not being a voice or representation on these panels or anything like that. Because I'm a person of color, I'm a first generation Colombian born person, LGBTQ, I'm gay, and so I'm there's so many layers, and all the layers of other communities are being brought out, but our layers are, it's either we didn't have enough engagement, no one really came, and so as Stephanie and I were both CHWs, we want our community's voices to be heard, because our community has a lot of needs, and the fear of being exposed due to their legal status, because our community also has an incredibly hard time getting legal status. Once they've stepped foot into the U.S., it's a lot. For one of the main things is I need a dentist, because I've never seen a dentist in my country, and having to tell them sorry, it's you have to wait about a year. But if it gets too bad, go to Maine Med, they'll just give you antibiotics. So what can we do to make sure that we're also included in these participation things? Because I'm so tired of seeing the other communities, but not ours.
Well, thank you for raising that. I mean, when I tell you we did a lot of outreach to folks in the Latinx community, to get a focus group, we did a lot of work. And at some point in time, we just had to say that we will get the data at another time. And so for us, we need to continue to do that. We need to commit that we're going to get the information that we need from the Latinx community, because I totally agree with you. We don't have an accurate picture, right? We don't have an accurate picture not only because we left out the Latinx community. We have an accurate picture because we left out so many other communities, right? So we need to talk to the Latinx community. We need to reach out to so many other communities. The disabled community, right? Their information is missing up there, right? And so this is just a start for us. And I know that probably doesn't make you feel better, but we should definitely talk, because we tried to gather the data from the Latinx community and it just did not happen. And I'm trying, I don't want to say that's an excuse, I'm just trying to give you the reality of the situation.
Regina, can I add something? So through this collaboration, I spoke with Stephanie when we were on the line, and as you know, we went to present the Maine. When I say we, I meant the equity program originally had a partnership with another entity, and unfortunately things didn't work out, but thanks to the generosity of Greater Portland Health Dental team, now we have a project for the Latino community, and I'm glad to hear that your voice is constantly, because it's not just me now, that it's always advocating for the Latino community needs, and I'm very strongly on that, because it's very difficult for me to not say that, because some people may think, oh, she's biased because she's Latino, but no, it's a reality in this inequity system. The Latino community has almost all the disadvantages to accessing all the care services that we are working toward health equity. So the great news is that we still have, up to this, 3 hours ago that I checked, we have a list of 43 patients, Latino patients that are on the waiting list, and we served 40 patients only in 12 hours last week with the Greater Portland Health. So I am very grateful to this partnership and to my Jena's team from Greater Portland Health. Please call our child. Tell everyone. I just spoke, like I said, with Stephanie. We send information to your program, I think it's wellness director. Yeah, Keiko knows about this. She has all the flyers, so possible. So we have to, until September 30, to enroll everyone, and Jenna's team is going to see all Latino patients. And the good thing about this program is that it's not just going to be one-time shopping, cleaning. No, they're going to establish a routine care. They will have a dentist for the rest of their life in Maine. Right, Jenna? Not asking for much. No?
But I also want to tell you, I believe you me, as a black person growing up in Maine, right, when it was 99.9% white, right, I certainly hear your frustration, right? And so what I want to tell you is unfortunately, you're still going to have that frustration, but I also don't want you to lose your voice in that frustration, because we still need to hear your voice when you say, hold on a second, you're not including me. Because it's really important for the Latinx community and all of the other communities to be included. And so I can say to you, for cross-culture, we will do better for the Latinx community, and continue to try to reach out to folks that we can include your community in our data, and we work with them.
I feel like I'm seeing a potentially missed opportunity emerging, particularly when we're talking about new arrivals who, like who resettlement agencies, that's like when I work at, who actually have a lot of high support to access resources, and some existing groups that are also may share like Hispanic heritage or Black heritage or African heritage. So there are people who are newly arrived who are looking to connect with their own culture in this new space and who need that connection. And then we have people who are underserved and underrepresented because they don't have access to those resources, and like how could resettlement agencies partner better to have this be a two-way street, to connect people who are new to Maine, who share that community with an underrepresented community who's having to access and care. And so all of the
great question because, you know, there's very limited research. Oh, sorry, did you? Oh, sorry. Yeah, it's a really good question because what's happening is in all of these communities, it's competitive, right? It's all competitive because we all need access. We all have different needs. And there's very few financial resources that we have, right? And it shouldn't be that way. What we should be doing is coming together as all of our communities to try to figure out how best to do that. There are language barriers, there are immigration barriers, and I think as far as communities of color, that's maybe the education that we need to do. We need to understand the different communities that are within Portland and beyond. Again, Portland and beyond Maine, the rest of the country. We need to understand. So we need to do some education about those communities and also find out what their needs are and also be an advocate for them. I hope I answered your question. Yeah?
I talked a little bit with Kathy about this, but I'm a medical social worker for people diagnosed with HIV/AIDS, and that's primarily a BIPOC population for me. We have all the funding. We've received so much funding through Ryan White Part B, through the Age Drug Assistance Program, through Medicaid. We have special benefit waivers. So I will go to a dentist with thousands of dollars, and they still will treat my clients like they're less than a human because they don't look like me. Do you have any kind of platform or can something be made where I can access a list of dental providers that aren't racist?
Yeah.
I have the funding. They'll take the Medicaid, they will take the Ryan White funds, but then my client doesn't speak English and they're like, oh, sorry, I can't schedule. And I call back a week later with a white client and they're like, oh, I have something on Friday. Like, it's very blatant that that's the problem.
Yeah, and if I can just add something to that is, and Emily's already familiar with this, but you know this problem happens to the trans community a lot as well. And at one point, being Transnet making some of the other LGBT plus provider advocacy organizations like created a directory of trans-friendly providers that was a really helpful way for people to identify that might be a safe place to go. And it'd be great if something like that could exist for BIPOC Mainers.
Probably the same list. It could be, you know what I mean? If you have a dentist that is willing to provide, you know, services to the trans community, then there's probably no judgment there, right? They've probably done their own work as far as racial and social justice, but I don't know because I don't know what the list is. But yeah, I mean, it's hard because you just don't know, right? It's just so hard, and so I don't necessarily know. I would not have a list. Maybe Children's Oral Health Network may have a list. Well, wait a minute, we have a dentist right here. Yes.
I am not a dentist, but I do have a dental referral list, but it doesn't include information on whether or not a practice has received.
What does it include?
If we try to update it with whether or not they're taking patients with Maine care, but that is a moving target, and there can be long wait lists, but we do our best to keep it as up to date as possible, and it's pediatric specific.
I was going to say, this was my next question. Is there a way to find out not only do they have hygienists to clean your teeth, but do they have dentists to follow up if you have a cavity or a need for root canal that's available? Sometimes you can go get clean, but they'll be like, I'm sorry, I'll put you on a list like a year from now for a root canal. So is there a list that if they don't have it in Portland, somebody else you can go to?
No.
In the same like community dental.
I can speak a little bit to this too, from the state perspective, where we did try to have a collaborative in the community. Remember this, where we did try to do some sort of centralized directory, because this was coming up so often. Who is taking what, when, where, who's open, what languages, and there was no centralized database that had that information, and unfortunately we still don't have that due to capacity and funding. The hope is at some point we have this magic list, right? But unfortunately it doesn't exist.
But it's in the works?
At some point.
Oh, it's not current.
It's a need, but that doesn't mean that all the initiatives are based towards that. It's on the list of, we know this is a need, but we don't have capacity, at least for the state as the CDC, to hold and maintain a list of that sort.
Do you have the opposite of a way to reach and bring in more dentists and hygienists and ones that can do cavity fillings but also a root canal?
Well, I think there's different initiatives across the state to incentivize different styles of care, but to say that that's like a state incentive, no.
There's no state incentive to incentivize.
Well, we incentivize like through student loan repayment, but to say that we're trying to add people to a repertoire or a directory through an incentive, I would say no. We know there's a need for a centralized database. What that looks like, I'm unsure. We attempted it once, I think it was last summer or 2 summers ago now, and we had multiple partners involved, and there was just no capacity for people to upkeep a directory of that sort, unfortunately.
And draw in dentists that could help with fulfilling the care, the full care.
And that's a whole separate issue of actual workforce capacity.
That's my question too. Are we trying to incentivize to bring in the workforce so it's not a year out for a root canal?
Yes.
We are trying to recruit for help like this. We're working on it, but unfortunately,
Incentivize is my question, because recruiting is one thing, incentivize.
Well, incentivizing the directory and recruitment they're all different. So speaking to the directory, we've tried, and there's hope that at some point in the near future we'll be able to rebring that group. Speaking to incentivizing
dentists.
Yes, there's multiple things happening throughout the state, and I can provide you more information on that. And then same with recruitment, there's different avenues of recruitment happening between Maine Care, between the oral health program and other partners, and trying to get more patients or more providers to take Maine Care. So there's a lot of moving pieces in that question.
Right? Yeah, thank you. No, that was great. That was exactly why I came today, pretty much to find out the
just remember our UNE students, when you're thinking of capacity too, like internships and field work and things like that. We have a ton of students who would love to get engaged in that kind of work that might help build some capacity at no cost for folks. So,
right. Every master's in public health, they're actively seeking field their practical experience that they have to do as an accredited program. And that's the work that they do. They're looking at the gaps and barriers, creating greater access to those things like that. So that's certainly something where you can have the free labor, honestly, and conversely, at the end of their program, people do more deeper research around those topics and can add even more value through evaluation and other aspects to their integrated learning experience, which is like their thesis work. So there's a lot of student work that can be pulled to add to all of the work they're all doing and fill in those gaps and barriers, look at data and analysis, and really break down where the limitations are or that existed in trying to access the Latinx population for your study. Where are those limitations and how to act on those specifically? There are so many ways, like PhD students and other students, that can be of great value, and it will fulfill their requirements as well.
Could you have a little class lab or a meeting like this where those students that are interested and these guys, so they can all meet at one point and get it efficiently met and go up to the dentists in the community if you guys have an event with those that offer them kids or adults, you can come here at 5 o'clock on Wednesday and there'll be a bunch of dentists offices looking for your assistance, and then stay on, everybody meets.
So what might be better is
we can talk about it offline. Okay, right.
Thank you.
Yeah.
Thank you. But I do want to get back to your question because I have a couple of thoughts about your question. First of all, we don't know who's racist unless we hear the stories. And if people aren't going to the dentist, then we don't know that we don't know, right? We could have somebody who goes to the dentist and feel like they were treated unfairly. And they may have been because they call this people, but we also don't know if that particular person in the oral health practice, I don't know if they just had a bad day. Right? I'm certainly not trying to make an excuse for racism and oppression, because it exists. Believe me, it's out there, and it exists. And it's hard to dismantle, right? But there are some times when I could go somewhere and I could say, you know what, I got treated badly, so I think that person's a racist. And that's actually not the case, right? And so that's the other thing where it's hard to have a list of dentists that aren't that are racist, right? What we need to do is we need to figure out who's doing the work, right? And you have two excellent organizations here. Community Dental and Greater Portland Health that are doing an excellent job of trying to reach to communities of color, have welcoming environments, have dentists that look like them. They have human students, right, that are trying to do the work. That's what we need to look at, right? Who are those folks doing the work? Children's Oral Health puts together several committees where they're talking with dentists. Those are the folks that are committed to making sure that their systems change. So what we need to do is we need to figure out who those folks are, because those can also be our champion and those can be our partners. The other thing we need to look at when we look at this is employment, all right, and training. And so one of the things we need to do that's really hard to do, and this is not about UNE, is we need to teach folks coming into the oral health field about cultural competency, about cultural responsiveness, right? We need to say, okay, are you taking this class, you know, on whatever that looks like, the intersectionality of health, oral health, race, LGBTQ+, Latinx, right? And it can't just be one class, right? And we also have to look at who is going into the field, right? Who is going into the field, and having conversations with them. And also allowing ourselves to have a dialogue when we all don't agree, right? I can have a conversation with somebody who I don't agree with, but at least at the end of the conversation, somebody says to me, you know what, I get it. I get what you're trying to say. Believe you me, this happens to me all the time. I can hear what you're saying, I just think of it as a little bit different. And we, you know, part ways amicably and, you know, whatever, at least the person understood what I said, and then I understand what that person said. So I think there's a lot of things that we can do to cut down on that, so that maybe at some point in time, we can all just access healthcare and we don't have to worry about racism. What other questions? Yeah.
I just want to add one thing in there. On the COMB website, there is an access map page, and it was part of the effort Kate was talking about. It actually started during COVID, when all the dental offices had to be shut down, and the only ones that were open were the ones that were taking emergencies. And so we created the map as a way of trying to say, like, who's open taking emergencies? And then it kind of, and actually it was the Maine Oral Health Centers Alliance, of which Community Dental is a member, and Maine T, and who created it. And then it just kind of evolved from there. Like, as COVID ended, people were like, don't shut it down, keep it open. And, you know, then we tried to add all of the federally qualified health centers and anyone else who was taking Maine care, who has a sliding fee scale, who's, you know, sort of open accessibility. And we were trying to provide information on, like, how long is the wait list, like, what is the process for making an appointment, what kind of services are offered. And so that is still on our website. It is really hard to keep it up to date. So it is not very up to date. Each listing has its own date of when it was last updated. And we would love some help, because I think it's really just going to take calling everybody on the map to find out what's your current status. And so that kind of help would be very welcome. And then I just wanted to say that in terms of, like, root canals brought up a really important point, I think, because I don't know if people realize that, like, there are so many different types of dental specialists. Like, there's general dental care, and then there's, like, if you need a root canal, you might have to go to an endodontist or orthodontist for, you know, braces, or oral surgeons for extractions. And there's so many different specialists, and we have very, very few of those specialists. Pediatric dentists are another one that's in really short supply. And so, and you often can only get the referral to the specialist from a dental home by going to a general dentist first. And it's like, if you can't get into a general dental office, you can't get into a specialist. But if what you really need is a specialist, the general dental office can't help you. And so you end up in this, like, no-win situation. And we don't have a single endodontist in the state that I'm aware of right now who's taking Maine care. We have very few oral surgeons. We have very
cleaning, 2 months later, 3/4 of my tooth fell out. I went to my office I go to, grouchy receptionist, and wouldn't help me, but a dentist, when I was relentless, came out and said, no, we can help her, she is a patient. And the receptionist kept saying, no, we can't. But the dentist took over and got me an appointment 3 weeks out.
Yeah.
So I had to go to my primary for medicine, which made it so now we can't do just a tap, because why was I on antibiotics? So now I have to be seen by somebody to tell me, does she need a root canal?
Yeah.
Now I'm in limbo, complete limbo. Nobody's answering their phone.
Yeah.
So it takes me I'm a Portland extrovert, so I'm very, I go out to the community and I'm asking all around, who can help me, because I can't live with this the rest of my life. So being here, I'm sure I'll get help now. But just being me at home, I was going to be in limbo. I was going to be in the dust of the wind, probably, for a while. And I do have amazing humans as a dentist, but he also is trying to help, 50,000 people or more?
Yeah.
So,
and this is really, really hard. Like, there is no easy solution to this aspect of it. And the people in this room who are all working on this challenge, I just trust me, I think we all go home in tears with how hard and how frustrating it is not to be able to come up with solutions to that problem. And that was actually what led to the If You're Frustrated poster, because they're we just have to keep raising that voice that we need investment from the state. Where's Tony? Tony just said, what about the dental commissioner, right? We need help. Really with some big strategies in terms of increasing that kind of crisis end of the continuum. We can keep doing all the prevention stuff at the front end that we're already doing, but the crisis end, there's not enough help right now.
Thanks, Becca. Appreciate that.
Thank you.
Any other questions? Any other comments? Anything that you guys are doing on your end? The other organization that I failed to mention, who is a partner in OHEC, is Minou Jones. Minou Jones does a really good job of reaching out to all communities. And so community dental, Greater Portland Health, Minou Jones, I would say, are 3 organizations that are really trying to look at this completely different. Any other questions? Any other comments? Yes.
Yeah, I have a comment. Just a story that kind of came out of today's discussion, that universities and others kind of supporting each other, because on that other end, as when I was in school, I couldn't get an intern and I had to literally wait another semester. And I almost lost it, because it's that fact that it also told me that if no one would want me for free, no one would pay me to work for them. So I was dismortal, but I was lucky enough to have kids that I was raising. So I literally became 200% mom and just dissolved in that and not think about what just happened. But it's really a tipping point for students who really have all their life put in to just go to school and experience that. Because, but then in a bigger picture, it will be helpful kind of supporting that free labor, so to speak, will have a greater impact in the community. So I really love this idea, because it just threw me back almost 5 years ago, but it's really an idea that needs to be harbored, invested in, and kind of put in a little bit of effort. Thank you.
With OHEC, we're really grateful that the University of New England is one of our partners. Dr. Lena does a great job, and we're very lucky that he, again, is part of our project. Is there something that we left out? Is there something that we didn't mention? Is there something that you're like, yeah, Regina, I agree, but? Or is there any other questions? I know in looking at the communities, you know, we have cross-culture, we have the OHEC, and then we work with the older population, and we haven't made that connection either, right? I mean, we're doing work with the older population, and we're doing work with oral health, and the work is great, but we need to connect the two. So that's some of the work that we need to do within the next year or so. Anything else? Anything left out? Anything else? Because if not, we get out of here.
I appreciate you talking about the trauma aspect of it too. Not only the seeking out and the finding, but the trauma after non-experienced dental workers, but some of the people, the dentists that are coming in, like the Harvard dentists and the dentists that are coming in from other states, I think they come because they have a heart for the lack of dental care here. And to just take me on as pro bono back with another experience to correct all that was done wrong to me and acknowledge, yes, Jamie, you hurt. All this was done wrong. You're living in pain for months. And so for that to be validated was huge and brought me back to a point where I could trust him and brought me back to a point where I would dare to go through any more dental work ever again.
Yeah. And that's why we have to hear the story. So I appreciate you telling us your story. That's why it's so important for us to hear the stories, right? And you stuck with it. You said, you know what, I'm going to keep coming back, right? You felt the respect from your dentist, right? And so it is also about the relationships. Everything that we do is about the relationships. And with the Oral Health Equity Collaborative, we're just so grateful that we and within our partnership with the Children's Oral Health Network, because they also allow us to come to the table and with others that are around that are doing similar work with us. So it literally takes everybody. And I feel within the oral health work that we're doing, we're not working in silos. Because we have folks on the local level, we have Cumberland County involved, we have state folks involved, and then it goes even beyond there. We have some rural folks that are involved. So we're all having these conversations within oral health. The only problem is it literally takes a long time to move a mountain, even an inch. So any last words, comments, anything from? Well, we really and truly want to thank everybody that came today. Truly want to thank you. We put this together with our partners, hold on. I just want to make sure I get my notes here, which I can't find.
Google Drive.
What is it?
Google Drive.
Yeah, it's not pulling up.
Gmail.
I thought it was in, it doesn't even matter. We just really and truly want to thank all of you for joining us today. We know you are all extremely, extremely busy. We also know that this is a really important conversation. And so again, we really and truly want to thank all of you. We also want to thank our partners, our Oral Health Equity Collective partners. We cannot do this work without them. We absolutely cannot do this work without them. And again, they come to the table every time we ask. They show up and they're doing some, and we're just very lucky that they show up every time we ask them to. So we really want to thank our partners for helping us. We want to thank Maine Care for coming today. We had a conversation with Maine Care and they said, no, we also want to figure out how we can partner with you and we want to make sure that we are with you here today. We want to thank Minou Jones for coming. As you know, she lives in Michigan, and so she came, and it was great to have her here. Two things that we want to remind you of is that we are doing our 5-part training series. It is open to the public. It starts in October. I think we have a slide that we can put up. You can go to the QR code, and it'll bring you right to how you can register. We're doing a 4-part training series. We're leaving out the equity plan piece of it. We're doing the 4-part training series. It's not on oral health, but it does give you information on the refugee and immigrant community, how they arrive, what their trauma history is, how they assimilate. We talk about white privilege and white supremacy culture because it's something that is real. There is white privilege. Our country was founded on a white supremacy culture, so it's really important for us to talk about that. We talk about the history of race. We talk about the history of oppression. And we also talk about cultural responsibility. So there's some information there. There's a QR code. You can go to our website. I think our website is up there as well. And you can go into the training piece. Now, what else did I leave out? I think that's it. Again, thank you. Make sure you take some food. And I really, truly hope that you have a wonderful rest of your day. Thank you.
Thank you.